Recording in progress.
The Fantastics. The Super Six has 6 global faculty who will be telling us and teaching us about the recent advances as well as key ophthalmology features as well as surgeries. So I'll introduce Dr. Steve Charles. He's the principal architect of the Alcon Constellation Vision System, performed over 38,000 vitreoretinal surgeries, lectured in 51 countries and operated in 25, delivered over 20 named lectures. He's the founder of Microdexterity Systems, which developed robots for dexterity enhancement for minimally invasive knee and hip replacement procedures. He's a mechanical and electrical engineer other than being a vitreoretinal surgeon. And he's also an airline transport pilot. He's consistently listed in the best doctors in America, and he's currently the clinical professor of ophthalmology at the University of Tennessee, United States. Professor Steve Charles, the floor is up to you.
Thank you so much. I appreciate being invited back to this symposium and seeing all my terrific colleagues on the screen. So let's get started with traction retinal detachment essentials. I'm a consultant for Alcon. There's no relevant disclosures here. My premise is that I hear people at meetings saying there's no need for scissors anymore in diabetic traction attachments. You can do it all with the cutters. And I completely disagree with that premise. The cases I see at meetings when people make that point are relatively straightforward traction attachments, not the so-called tabletop with broader areas of epiretinal membrane use. I also see people think it's routine to use silicone in these cases. Silicone oil is bad news in the diabetic traction attachment. Try to avoid it. I also see people hung up on older technologies like vertical scissors, which you only should use in a 27 gauge situation because curved scissors won't fit. So I'm going to emphasize use of scissors, particularly curved scissors, and why not oil? Why not oil? Because it causes silicone oil macular edema, which we abbreviate SUM. It causes emulsification glaucoma. But specific to the diabetics, it's because it has a very low oxygen extraction ratio, so it enhances retinal ischemia. When you take the vitreous out, you increase the viscosity 800-fold, allowing oxygen to diffuse from perfused areas to non-perfused areas. But when you put oil in place, the oxygen can't diffuse, unlike liquid perfluorocarbon. The other reason is because you sequester VEGF as well as basic fiber growth factor, fibronectin, and reactive Mueller cells at this oil retinal interface, and you can't deliver anti-VEGF drugs. There's 2 types of delamination with the cutter. The cutter delamination does work better than ever before because the cutting rates are so fast and the fluidics are so much better, and we have beveled cutters. Fold back delamination, you'll see graphically momentarily, works with flexible epiretinal membrane, whereas conformal delamination works when it's rigid, and it's called conformal because you must rotate the cutter around its longitudinal axis to control the angle of attack and follow the retinal contour to try to keep retina out of the port. So this is conformal, so you can see a relatively thick and rigid membrane is engaged in the port. It's hard to get the geometry right in a 2-dimensional screen here, but you can get the idea. And this shows you with it folding back with a thinner membrane that's more flexible. Both work, and both of the technologies or techniques rather have enhanced our ability to do traction attachments. That said, there's a reason to do scissors. So what are they? 1, if the epiretinal membrane is adherent to the macula. 2, if there's a broad zone of adherence, which has historically been called a tabletop traction attachment. 3rd, if the retina is thin and atrophic, which is the farther you get away from the posterior pole, the thinner and weaker the retina is, as Macular taught. If there's a heavy prior PRP or marked ischemia, it also causes thinning. And of course, chronic TRDs have atrophy as well. Which scissors should you use? Curved. Why? Because blade thickness is less than blade width. And it's a potential space between membrane and retina. Vertical scissors require a larger gap to get the down blade or the distal blade in this potential space. And the back wall of the eye is curved. Why not use curved scissors? Skis do not have a downward curve. They're not flat on the front. Skis curve upward for a reason. So the top slide is what I use, 25 gauge scissors. If I do 27, I would have to use the straight scissors because the top ones won't fit through the port. This shows you the role of, 45 years ago, I invented segmentation. What's segmentation means cut the epiretinal membrane up into pieces. But what do I use it for now? Largely for access segmentation, to gain access to the delamination plane. So you then rotate the scissors in your hand around its long axis, and you convert from the access segmentation to delamination without an instrument swap. So how should you enter the scissors? Don't enter closed and open them like you do in blunt dissection and general surgery. You'll rip the retina because the adherent zones are stronger than the retina itself. Similarly, don't introduce the blades wide open and then close. You should have them almost closed and make small snips right at the tip. So this is what happens if you spread, you cause retinal breaks. This is an attempt to depict the right way to do it when you move back and forth from side to side using these small snips, and the membrane will scroll up on its own. There's no need for viscodissection. It's okay to use bimanual surgery, but it's unnecessary. It adds complexity because you have a fourth port, and chandeliers do not provide the same quality of illumination that a focal endo-illuminator does. So I much prefer the endo-illuminator, and I use it as a blunt instrument to reflect back the membrane that's, for the large part, scrolling up on its own. What direction of delamination? Sometimes you don't have an option and you have to use outside in, but it's preferable to start near the optic nerve and delaminate outwards along the temporal arcades. Obviously, the macula getting reattached is your objective. Leaving a little traction attachment nasal to the optic nerve head doesn't hurt anything. Remember that the epiretinal membrane is not cancer. The point is to get it all out. So this shows inside-out delamination in a patient that has not had a PVD. The idea that you must first do a core vitrectomy, there's no core in traction attachment. Second, you must make a PVD. Don't forcefully make a PVD, or you make retinal breaks and you'll say, oh, it was a complex TRD, I had to use oil. No, you did it wrong. So this shows you removing the posterior vitreous cortex, which is contiguous with the epiretinal membrane in every case. So this idea that it should be called en bloc is ridiculous. En bloc means in one piece. That is not what you want to do. And the original paper from Milwaukee on en bloc said use outside in dissection and use the vitreous to pull on the epiretinal membrane, which is a very bad idea. You should. Their second paper did it the way I suggested, which is inside out delamination. So again, forget the term en bloc. And forget the notion of en bloc, and do access segmentation followed by inside out delamination. And if there's no PVD, don't worry about it. It will present itself to you as you delaminate outward. Where does peeling fit? I underutilized brilliant blue staining and ILM peeling in these diabetics because there'll often be a little epimacular membrane. How should you achieve hemostasis in these cases? Lasers better than diathermy. I published this some years ago with Stanley Chang and Brooks McEwen, and it was a concept that I came up with because our lasers switched from near IR 800 nanometers or so to green 532, and the advantage of that is the green light is absorbed in the red hemoglobin column, whereas if you use the radiofrequency energy diathermy, there's a larger sphere of damage, and you cause what you later believe to be ischemic or atrophic breaks when in fact they're necrosis caused by diathermy. So in summary, don't do forceful PVD creation or membrane peeling, or you'll make high incidence of iatrogenic retinal breaks. If you don't use the scissors, you'll have a high incidence of iatrogenic breaks. If you have iatrogenic retinal breaks, you tend to use oil, which reduces interretinal layer oxygenation, sequesters reactive Mueller cells and basic fiber growth factor, VEGF, and cytokines, the retinal surface, and prevents VEGF access. And obviously, it causes the well-known siliconal macular edema, emulsification, glaucoma. Use a 20K bevel tip cutter that Alcon developed. Use curved scissors. Use laser hemostasis. It's better than diathermy. And forget about a scleral buckle. It does nothing for posterior pole disease like this. And forget about dissection. And one thing that's not on this slide, and this is my last comment, there's too much phaco-vit going on around the world. The refractive outcomes are ridiculous. Lisa Arbesser and Steve Arshner can certainly comment on that. But when you have a traction attachment, what's the axial length? Unknown. If you have a diabetic vitreous hemorrhage, what's the axial length? Unknown. And I find that the vitreoretinal surgeons that do phaco-vit in every case forget the fact that vitrectomy doesn't cause cataract if you use high quality infusion fluid. It causes progression of pre-existing nuclear sclerosis. So you have a 20-year-old type 1 diabetic. Should you take the lens out just because they might get a cataract in 20 years? Ridiculous. Give them 20 more years of accommodation. So too much phaco-vit going on around the world with ridiculous refractive outcomes. Well, I finished in 10 minutes. Thank you very much.
Thank you very much, Professor Steve Charles, for a very enlightening lecture, and we really enjoyed it. A question to you would be, when do you plan your cataract surgery, if and when you do it? You do it a separate session, and how much gap do you keep between the cataract and the vitrectomy?
That usually applies to not just the diabetic retraction detachment, but it applies to all the macular surgery we do, macular holes, macular schisis, etc. So what I do, if the patient has 3+ to 4+ NS or a posterior subcap, I send them to the cataract surgeon because I don't dabble in cataract surgery. There's too much to get and I tell them you must measure with low coherence interferometry, not with a scan. And that because it measures from the pigment epithelium and you'll get the axial length right. If they can't do that, you're going to get poor refractive outcomes. You got to do the best you can. I find that the phaco-vit surgeons around the world, which is not so true in the United States, don't use Aura or Varion and other technologies like that, don't use torics. So again, the refractive outcomes are bad. Now, if the patient has, I let a month go by after the cataract surgery if they do it first. So if they have 3+ NS or PSC, they've got to operate before I do, and a month goes by. If they have 1 or 2+ NS, you see way better in the operating room than you do in the office because of endoillumination, and you can just go forward with the vitrectomy and let them do the cataract surgery a month out.
Any questions from the panel? Dr. Peter Kaiser? So any questions from you?
Questions. I think what Steve says is the way I operate too. It's interesting how people talk about how they use 27 gauge in particular to do everything just with the cutter. And I agree with Steve. You know, maybe they do easy cases, but the cases I do, a curved scissors is really vital. And I do modified and block, sort of what he does. So you do it right, the surgery goes well.
Thanks, Peter.
I just want to agree with what you said, Steve, about phaco-vit. I agree with you precisely. To do retinal surgery too early after cataract surgery before the lens is stable, I've had patients come back with the lenses out of the bag. And to try to do both, you're right, the accuracy is not good. I've had to do lens exchanges for the wrong lens power being put in. So I agree with you. I think we should each stick to what we're good at.
And Steve, to your point, I was talking to a number of KOLs for Alcon privately, one-on-one in these phone interviews I did. And I asked them questions like, who's Graham Barrett? They said, I don't know. Who's Warren Hill? I have never heard of Warren Hill. Have you ever heard of Arthur Cummings? Who's that? What about Doug Koch? Never heard of him. And I mean, really? I mean, please, you're what? You're stuck on the holiday too or something? And so it's just unacceptable, the refractive outcomes.
I like, Steve, the way you do your inside out technique. And actually, I used to call some of my peelings unblock, but actually, especially for diabetics in diabetic retinopathy, we were removing vascular tissue. I agree with you that the term that we are using oftentimes is not correct.
Unblock's a misnomer.
Thank you very much. I'd like to move on to the second speaker for today. Having authored over 7 textbooks, 30 book chapters, and more than 400 peer-reviewed manuscripts, being the principal investigator in over 60 trials evaluating newer treatments for AMD, diabetic retinopathy, and other disorders, editor-in-chief of Retinal Physician on the editor board of American Journal of Ophthalmology and many others, one of the top 100 most influential ophthalmologists in the world, professor of ophthalmology and Cheney Family Endowed Chair in ophthalmology research at Cole Institute at Cleveland Clinic, I'd like to present Professor Peter Kaiser. So the floor is yours.
Thank you so much. I wish I could be in India right now. I've actually never been to India, but with this pandemic raging everywhere and everybody worried about this new Omicron variant, maybe it's safer here. I don't know. I think our vaccination rates are peaking a long time ago. We have a lot of people sticking their heels in, which is crazy to think that they're doing that. So today I'm going to speak on dry macular degeneration and some of the emerging treatments that we're using to treat this very vexing disease. Here are my financial disclosures. So what is the issue? Well, the issue is that dry macular degeneration, particularly the late form, where you develop geographic atrophy, is dramatically increasing throughout the world. But more importantly, as the population ages, you can see here the prevalence dramatically increases as we age. So we have a dual problem. The bigger problem is we have no treatment. Even the ARADS formulation does not prevent geographic atrophy. So essentially right now we're doing nothing to treat this. So if we look at the different ways to treat macular degeneration, really the issue is we don't have a smoking gun. We don't have a VEGF, so to speak, in dry macular degeneration that we could target. And so because of that, we're targeting many things just to see what may work. So the first area we know is involved in macular degeneration and dry macular degeneration is that the constant oxidative stress from converting light to impulses produces oxidative damage. In particular, if you look at the mitochondria of patients with dry macular degeneration, they are in a disease state with the cardiolipin being disrupted in the mitochondria. So one company, Stealth Biotherapeutics, has a drug called elameprotide that takes these damaged mitochondria, binds to the cardiolipin, and restores the mitochondrial function. And they did a phase 1/2A study called the RECLAIM study. And in that study, they showed improvements in visual acuity, but they also, which I'm not showing here, had a reduction in geographic atrophy progression rates. So this drug is being tested in phase 2B currently in the RECLAIM 2 study, and we'll have the results of that early next year. Another drug in this space is called rizatriptan. Rizatriptan is a pan-integrin blocker, so it blocks integrins. So because of that, it has anti-angiogenic and anti-inflammatory effects, but also through integrin beta 5 has mitochondrial stabilization effects. And it also did a phase 2A study. And in that study, almost half the patients had a gain of 8 letters of visual acuity, and about 1 in 5 had a gain of 15 letters. So a very significant gain in visual acuity. A phase 2B, phase 3 study is currently being organized. Now, early on, we thought, well, we developed these toxic byproducts in the form of drusen formation. So maybe we could reduce this toxic byproduct accumulation. And one of the big factors within drusen is amyloid beta. And amyloid beta is ubiquitously expressed throughout the body, especially in the central nervous system, and it's excreted extracellularly by neurons. And it starts with this amyloid precursor protein, APP, right there in the center. And that goes through 2 different pathways. In the pathway to the right, you produce amyloid beta monomers and then toxic beta or oligomers. And what's really important to understand is that the monomers are required for normal synaptic function. It's the oligomers which are toxic, and there's different forms of oligomers. And this also, of course, is important in Alzheimer's disease, where these oligomers form toxic plaques within the brain, leading to Alzheimer's disease. So the goal here is to prevent the formation of the toxic oligomers, but keep the formation of the monomers, which are important. So if you look at drusen, within drusen, amyloid beta is found within amyloid vesicles, and these are in very close proximity to the basement membrane. And if you think about what really happens due to this amyloid beta is a scaffold for this drusen formation. They cause complement activation. They produce pro-inflammatory changes. So amyloid beta seems to be very involved in macular degeneration. So how can we block it? Well, one company called Galimedics has a topical, a drop, which binds to these monomers that are misfolding, preventing them from becoming oligomers. Instead, they become these clusters. The clusters do not go on to form plaques, for instance, or other problems. So you're basically taking the issue, and instead of making it go down the bad pathway, you're blocking that bad pathway. Here's some examples of some preclinical data using this molecule. Again, it's an eye drop, showing, for instance, in the middle, the RPE, when under stress with amyloid beta, has lower patch clamp membrane potentials. That's blocked by adding this drug. This drug is about to enter testing. Another drug that works in the space is called Alseon Alz801. And this is different. This is a prodrug that produces a naturally occurring anti-oligomer 3-SPA. So 3-SPA prevents these monomers from forming into oligomers by basically turning them into cyclic structures that can't form into these toxic oligomers. This drug was being tested currently in Alzheimer's disease with very positive results in one phase 3. A second phase 3 is currently ongoing in Alzheimer's, but it's a pill. So we hope to be able to use this in dry macular degeneration shortly. We also know that DHA is very involved in the formation of toxic metabolites. And so if you take an oral deuterium stabilized DHA, this prevents the formation of lipid peroxidation, which is one of the toxic effects on the RPE. And this also being a pill will be great for this disease. Well, as I mentioned, the visual cycle is very active, and it depends on the retinol being brought to the RPE. When it is there, the debris from the toxic metabolites are internalized within the RPE, leading to RPE damage, eventually apoptosis and geographic atrophy. One of the main fluorophores that we look to see this type of toxic accumulation is A2E. This accumulates within the retina. We can visualize it with fundus autofluorescence. And so several companies have tried to use visual cycle modulators of different sorts to prevent the toxic cycle. So far, 2 drugs have failed, including a very large phase 3 by Acucella. But Alkeus, which has a deuterium-enriched vitamin A formula, which is a pill that prevents the formation of A2E, is currently still undergoing testing. Now, if you listen to the nightly news, you'll hear that stem cells cure everything, including dry macular degeneration. But unfortunately for all of us and our patients, this is not yet true. Companies are, however, testing different forms of human embryonic stem cells. And the ones that I show here, Lineage and Regenerative Patch, have used the idea that you don't simply inject embryonic stem cells in the subretinal space. That's simply not going to work, because the stem cells, to become RPE, need to be polarized. So these 2 companies are using a technique where they place the RPE, the early embryonic RPE, onto a scaffolding that's rolled like a taco and inserted into the subretinal space, thereby ensuring polarization of the cells in the eye. The early results in phase 1 have actually been very positive, but this is still too early to say if it's going to work. On the bottom there, J-Site has produced a retinal progenitor cell that they inject intravitreally, and they've tested this now in retinitis pigmentosa and have showed those patients have a significant visual gain with this treatment. If it continues to work, geographic atrophy and dry AMD is the next place that drug will go. The area of biggest excitement right now is the idea of suppressing inflammation, specifically by inhibiting the complement system. So if you think back, this is the complement system, and it was one of the first areas that in dry macular degeneration, we found a genetic association with genome-wide association studies, the so-called GWAS studies. And the first one was actually complement factor H on slide right. But since then, many other aspects of the complement system confer risk of developing macular degeneration. Moreover, histopathologic studies of patients with macular degeneration also have numerous complement components found within histopathologic specimens. So it makes sense to try and target the complement cascade. One company is targeting C1q, which is in the classical pathway. And why would you want to do that? Well, if you look in the slide center there, the usual activator of C1q is clustered antibodies, IgG, but other things that activate it include C-reactive protein, as well as what we already just talked about, amyloid beta. C1q is found in high levels around geographic atrophy, in PAT specimens, as well as around drusen. So a company has an inhibitor of C1q, which is a Fab fragment injected intravitreally. This just showing improvement in photoreceptor function with the use of ANX007. This is currently in phase 2 clinical testing. Most of us feel that the alternative pathway is probably most involved, and the reason for that is the alternative pathway in our bodies is the most active. Genentech Roche has an antisense molecule that produces an inhibitor to factor B, which is the part of the enzyme that produces the alternative pathway and allows the autohydrolysis that occurs in that pathway. Factor D has been discussed in the past. In fact, there was a very large phase 3 program by Roche called lampalizumab, which failed. But other companies are looking at factor D, and the reason is that factor D is the rate-limiting step of the alternative pathway. So it makes sense to target that. You know, there are reasons why lampalizumab failed. Recall that the phase 2 study of lampalizumab also was negative. Now, the problem with the alternative pathway is it produces C3b on the surface of all cells, including our own cells and the RPE. So if we don't turn this off, we will have damage to our own cells. And the way it's turned off is with complement factor H using complement factor I as the cofactor. So the two are very involved in turning off complement damage. So the idea then is if we have abnormal complement factor H or complement factor I, which produces macular degeneration, why don't we give back to our bodies normal factor H or factor I? And so that's being explored by two companies, Factor I with gyroscope and catalyst. The difference is gyroscope is gene therapy, so it's going to produce this recombinant factor I for the patient's lifetime. And this is currently in phase 2 testing. And another company is looking at delivering intravitreally recombinant complement factor H. And this just started phase 3 testing in the worldwide phase 3 test currently. Now, the area that's gotten the most excitement is at C3 and C5. And the reason for that is you could see if you block C3, you block all the different pathways, irrespective of what started it. There are 3 different companies looking at the blockage of C3. The furthest along is Apellis with pegcetacoplan. And in the pegcetacoplan phase 3 study, one of them was positive for the overall group, but it was also positive in the non-foveal lesions. The second study overall was not positive. So it had 1 positive study, 1 negative study. But if you look at secondary outcome of these non-foveal lesions, both studies were positive. So this is going in front of the US FDA this next year. So we'll find out if it'll get approved. Now, one of the interesting side effects of this treatment is it's producing higher rates of choroidal neovascularization. And it's a little unclear why this is occurring. There are many theories, but no real known reason that CNV is produced by blocking C3. C5 is also being looked at. Of note, there were 2 companies that had failed studies blocking C5, but we now have a positive phase 3 from Iveric Bio with Zimura. This is the GATHER1 study, which showed a significant reduction in GA progression at 12 months. This is a phase 3 study. And that difference continued to increase at 18 months. But the other thing that's exciting that came out of this study for all of us is they showed that the drug also prevented the progression from incomplete GA or iRORA to CRORA, which is complete geographic atrophy, as well as prevented the formation of atrophy from drusen. So if you really think about it, all these drugs I just talked about, we shouldn't really be testing it in geographic atrophy. We should be testing it earlier. However, that regulatory pathway is much more difficult, so all the companies are looking further along. Janssen has a gene therapy product that produces CD59. CD59 blocks the formation of the membrane attack complex, which is the terminal aspect of the complement cascade. This is about to enter phase 2B testing as we speak. Now, complement inhibition seems to really work well, but we don't know many things about the complement system. We don't know, is it mainly the alternative pathway? Is it mainly the classical pathway? We don't know what causes the complement activation. Is it the amyloid beta, or is it something entirely different? We don't know if we treat patients so late in life, if it's going to actually work. Do we need to treat earlier in life? The majority of the complement in our body is produced in the liver. So should we be doing systemic inhibition, or should we do local injection? So there's many things we don't know, but what we do know is we're starting to see some positive results from these studies. Now, if you look at genetic studies for macular degeneration, the only mutation that actually specifically increases the risk of geographic atrophy is overexpression of HTRA1, which is a protease that's expressed in the RPE. And some of these substrates for this protease are the extracellular matrix proteins. So companies are looking at blocking HTRA1. As I mentioned, in mutated patients have increased levels of HTRA1. So Genentech as well as Iveric Bio are looking at inhibiting HTRA1. They're currently both in phase 2 testing. And finally, I just want to talk about some of the other approaches that are out there. We know that, for instance, C3a and C5a activate inflammasomes, and inflammasomes produce damage. 2 companies are looking at inhibiting inflammasome activation. Lumathera has a light model to prevent the damage using photobiomodulation. And another company is, instead of using light, is using low-dose microcurrent. And again, both these approaches, it's a little difficult to explain the mechanism of action, but one is using light, one is using microcurrent to induce changes to prevent dry AMD progression. So as you can see, Many different companies, many different approaches. And the main reason for that is we don't have any good animal models to test to see if a drug would work or not. I showed you many of the current treatment strategies, and although clinical trials are underway, we still don't have a treatment for dry macular degeneration, but we're very close. And hopefully in the next year or two, we'll actually have a drug to treat macular degeneration. Thank you so much for listening.
Thank you very much, Professor Peter Kaiser, for a very interesting and comprehensive talk on dry AMD. I'd like to now welcome a third speaker. He's published more than 440 articles in peer-reviewed journals with a focus in the field of choroid. He is the editor of books Choroidal Disorders, Sentinel Series Retinopathy, and Choroidal Neovascularization. He has delivered the inaugural Iron Constable lecture at the APVRS in 2016. He is my teacher and mentor at LV Prasad Eye Institute, Hyderabad, India. He is currently the vitreoretinal consultant at University of Pittsburgh Eye Institute, Pittsburgh, United States. Dr. Jay Chablani, so the floor is yours.
Thanks, Trevor. Thank you so much for the kind invitation. It is a pleasure to be speaking on this meeting. And after listening to Peter's talk, I feel that we really need to dig down into the imaging so we can actually find the predictors for the progression. Let's talk about what we are really excited about choroidal imaging in 2022. Are you able to see my slides well?
Yes.
Perfect. So these are my financial disclosure. None are relevant to this presentation. So we have been looking at choroid through very conventional ways, ICG, ultrasound, then came the EDI using SDOCT. And then finally, we have swept source OCT, which provides us a detailed architecture of the choroid, almost as good as what we can see on histology. But what are we looking next? We all have started using dye-based angiography using these beautiful wide field ICG, where we are able to track down these choroidal vessels, their arrangement, their association with these vortices. And this is where we are now going to come up with a venous overload choroidopathy. And this is one of our interesting paper, which we recently published in PRER, where we are trying to show that most of the diseases such as CSCR or PCV have an associated venous overload choroidopathy, which is possible to image by using these wide field ICG, as you can see on these pictures. And we are able to see the relationship between the superior and the inferior arcades of the choroidal vessels and their communication with each other. What is going on with the structural OCT? We showed the automated choroidal segmentation a couple of years ago. Now we are able to use this choroidal automated segmentation to produce a biomarker called choroidal vascularity index. And in last couple of years, we took this work forward, and now we are able to come up with something called as choroidal vascularity map, which has been borrowed from our ETDRS map for retinal thickness. And with the use of these choroidal vascularity map, now we will be able to talk about the choroidal vascularity in each sector, as we were talking about various focal diseases such as AMD, or which part of the irora is actually converting into cirrhora, which Courier Capillaries layer, which part of the choroid is being affected to cause the progression. These maps are going to be useful. We briefly started using these maps and published a couple of recent papers where we are trying to show that in CSR eyes, these choroidal vascularity map will show an increasing trend towards the center and in the CSR eyes. We also used these choroidal vascularity map to understand what happens to the choroid at the focal areas of leak, as you can see here. And we reported that choroidal vascularity index changes more diffusely spread and local changes in CVI, which is not predictive of leakage location in active CSCR, which clearly defines that this disease is a diffuse disease, not just that focal area is the problem, but we should be looking at much more larger area while treating these patients. We also looked at choroidal vascularity pattern, and there are some of the work which is coming along where we are showing that the reticular pattern is more common in CSCR eyes, while herringbone patterns were more common in fellow eyes. So these choroidal vascularity vessels pattern is going to show us that if this eye is more prone to develop a CSCR or PCV eventually during the follow-up. We went a little deeper and we looked at the short posterior ciliary arteries. Here you can see shown using an arrow where we are showing that how these short posterior ciliary arteries are entering into the choroid. We went ahead and got the segmentation done at the posterior border of the choroid, and you can see the middle picture where we are showing these multiple short posterior ciliary arteries, how they are entering into the choroid, and now we are looking at the distribution of these vessels in various disease patterns that this eye could have been prone to develop a choroidal neovascular membrane. And while we are treating these patients, what changes are going on in the posterior part of the choroid. We went ahead and we really want to look into the 3D model of the choroidal vessels, because we understand that the choroidal vessels are not present beautifully like we expect in retina. They are not layered, and this is where the challenge was to actually. With the help of machine learning algorithms, we are able to now see the choroidal vessels in 3D, as you are seeing on this video, where you can see the vascular arrangement, how the vessels are changing the directions in 3D. Let's look at this picture from this video, where I would like you to focus on this particular vessels. And now you can see these individual vessels in much more detail. Here you are able to see the wall, the diameter, the changes in the diameter, and if there are any focal changes. Let's look at the picture from a patient with CSCR, where you can see the vascular arrangement, the pattern, the changes in the diameter in 3D. This is a representation comparing a healthy patient on the left and a patient with CSCR on the right. Let's look at these choroidal vessels in this eye with CSCR. Here you are able to see those individual vessels in much more detail. What we see is the focal constrictions and the crossing changes. Let's move on with the Courier Capillaries on Ocd angio, because this is becoming more and more commonly used. Now we are coming up with various indices looking at the Courier Capillaries, such as flow deficit matrix, global average flux index, and global fluctuation index. And there is some work going on where we are trying to look at the 3D segmentation of these Courier Capillaries. But what is up and coming in the clinic, which is not still in the clinic, is something very exciting, such as laser Doppler holography. This is a powerful imaging platform for evaluating the structure and function of retinal vasculature and choroidal circulation by using these non-invasive method. And here you can clearly appreciate, by using the power Doppler variations, we are now able to image these choroidal vessels non-invasively. I can show you something more interesting by using this LDH machine. Now we are able to not only see the deeper choroidal vessels, but we can differentiate between the choroidal arteries and choroidal veins, which was not possible even with the ICG. This is a very good example where we are comparing the LDH images with the ICG as well as structural OCT, as you can see here, and these beautiful images clearly differentiate the choroidal arteries and choroidal veins. And I'm really excited about this technique. We are bringing up this technique in Pittsburgh in collaboration with Paris. We are also working on AO-ICG imaging, where we can use the AO system for looking for these Courier capillaries, as you can see on the image on the right, which is showing you these microstructure of the Courier capillaries, which is almost as good as what we see on an EM imaging. So by using this ICG with AO imaging, AO-ICG demonstrates the dye entry and exit, which allows us to visualize the Courier capillaries, which was not possible in available imaging modalities. With this, I would like to thank everybody for their attention. Thank you so much for the kind invitation.
Thank you very much, Dr. Jay Chabdani, for a wonderful talk on the upcoming advances in choroidal imaging. We can take up a question. Dr. Peter Kaiser, Dr. Steve Charles, what are your thoughts on the choroidal imaging as well as the dry AMD concept?
Fascinating. I think one of the things that would be very interesting is to correlate Jay's imaging with sort of longitudinal looks at patients who go from drusen to IROR and CROR, because we think that underneath that we'll have some flow abnormalities. We think there's been some suggestion of that by some authors, but I think some of his techniques would really be able to bring it out much better than some of the techniques we've been using.
Thank you.
Thank you very much. Thank you, Dr. Jay. And thank you, Dr. Steve and Dr. Peter, for the wonderful talks. We can move on to the Dr. Reena.
Yeah. So our next speaker is a very prolific surgeon, and she's an adjunct associate professor at the University of Utah at the Moran Eye Center. She's a frequent visiting professor at many residency programs and a former president of the American College of Eye Surgeons. That's Dr. Lisa for all of us. And she regularly gives us a course on the vitrectomy for anterior segment surgeon and has an interest in complex cataract cases as well as refractive cataract surgery. She's a really dedicated and a passionate teacher and an innovator. So over to her. She'll be talking to us about traumatic cataracts. Dr. Lisa?
Dr. Lisa, you're mute.
Dr. Lisa?
Yes, can you see my slides now? Can you hear me and see my slides? Yes.
Yes, we can.
Okay, very good. Sorry, I thank you very much for the invitation to be here and in such amazing company as you have here. So from the sublime and the scientific to the more practical, I'd like to talk about one case that illustrates so many issues regarding the principles of anterior segment reconstruction in traumatic injury to the lens. And let's see, this says, I'm sharing, but it's not going on to the next slide for some reason. There we go. Okay, no financial disclosure. So an 11-year-old boy presents with a near total hyphema after a BB gun hits the closed lid of the right eye. Hand motion vision with projection, excellent light projection, a pressure of 30. There was no reverse afferent pupillary defect in looking with log unit neutral density filters in order to make up for the difference in pupil size, and no reverse so he was managed conservatively. A B scan later showed that the retina was intact. So we're talking about anterior segment problems. He was managed conservatively with steroids and topical Cosopt and Asopt. As long as we can control the inflammation and the pressure, we want to delay surgery as much as possible. The eye quiets, the hyphema absorbs. We did not have to remove it acutely. The IOP was controlled, so we were able to wait 2 months for surgery, which gives tremendous advantage in terms of fibrosis occurring in the lens. So all risks were discussed, particularly retinal detachment and corneal edema, infection, permanent glaucoma, glare, irregular pupil was possible. You'll see the picture in a moment. The family was prepared that he might be aphakic, and the IOL was calculated based on the fellow eye, however, because we were unable to get any good measurements on this one, and he was previously symmetric in his refraction. There was potential need for more than one surgery, which was discussed with the family ahead, and of course, general anesthetic risks. So 180 degrees of iridodialysis was found. There was anterior capsule rupture. B scan, as I said, indicated a normal posterior segment, which would have changed the entire approach to this case had there been a retinal involvement. There was probable zonulisis, an unknown posterior capsule status, and anterior and posterior synechia, and that's what the and see that there's quite a bit of disorganization. And our goal is to sort of find all the proper layers and put them all back together and try to avoid the posterior segment becoming involved if possible. So we'll start with this video here. And the goal is, first of all, to make sure the pressure is good at the opening, and that may require some IV mannitol, and then immediately going in with triescence diluted to see if there's any vitreous involved, because we need to treat things quite differently if so. I chose in this case to not use any irrigation, but rather a dry technique with quite a bit of OVD being used, using a Arshner reverse shell in the sense that dispersive was used over any area of possible break and then cohesive to work in. And now we're trying to establish the normal planes and trying to reduce the scarring between the iris and the lens material. And you can see we're just doing that very gently. Speed has nothing to do with this kind of a surgery, because we want to use blunt and, if necessary, sharp dissection to be able to slowly but surely develop the proper planes and find the lens. Then we've also used trypan, being very cautious not to allow it to go around broken zonules, where we would then have a blue reflex rather than a red one, which would be challenging, and ergo what Steve Arshner has taught us about the use of OVDs makes that possible, to keep it painted onto the surface of the lens and sequestered from the posterior segment. I'm using dry aspiration then with a 26 gauge needle to remove the flocculent cortex and begin to try to find all of the anterior capsule and make sure that the posterior capsule is intact. So using no irrigation during this keeps excellent control, though it takes a little bit longer. We're going to try to now reduce some of the posterior synechia, and eventually we'll do a little bit of a goniotomy as well, or goniosinicolysis really, in order to try to make covered trabeculum function again if we're fortunate. So we're reducing the plane. You can see the iridodialysis on the right, and we're trying to separate the iris from the lens. We're starting to get some good red reflex here. So we'll review some of these principles, but basically you can see it's a bit of a labor of love, because we're going to remove everything so slowly. Here's the goniosinicolysis. I did add some subconjunctival lidocaine with epi, mainly for the homeostasis down below, where we're going to do the iridodialysis repair. Goniosinicolysis can be done with a gonio lens, but it's not necessary. We know we're pulling it out from the area, and we didn't get great hemostasis with our epinephrine, but it's worthwhile to try. I don't like to use cautery ever on the sclera if we just avoid penetrating vessels. It's very unnecessary most of the time with a little patience, sometimes a little gel foam, and that way I think we avoid melts. I think the sclera is poorly enough vascularized as it is. Using a straight double-armed tenoproline, we can then nicely decide where we're going to place that. I always have a nurse watch that I don't penetrate and that needle has to be taken off the field because it's contaminated. So one must always have someone keeping a view of that. In a small child like this, it's a little more challenging with a deep socket not to penetrate. So that's a tiny little pearl that will keep you out of infection trouble. Things do heal better if you do not use cautery. So although the heme on the surface is a little bit annoying, it's really of no concern. Once our goal is just to drape the iris into proper position and not to keep it tight. And of course, we must bury our knots, as you just saw. And now I'm using a bimanual method of OVD, and I've decided that there's enough anterior capsule in V pattern above and no break that I can find below. So I'm placing a three-piece IOL actually in the bag. And I'm able to be certain that that's sequestered underneath that V of anterior capsule that you see. The posterior capsule appears intact throughout. At no point did I find any vitreous forward. So we've applied our sutures and things are looking awfully good. And actually at 3 months post-op, we wanted to wait 3 months to do a YAG laser. He was 2060 immediately post-op, and 2025 after a YAG laser capsulotomy was done. You can see there was a little opening here, which was interesting, that I hadn't seen during surgery in the anterior capsule. That's why we couldn't find anterior capsule, presumably. At any rate, we've made our opening in the posterior capsule here, and there's a strut of posterior capsule that goes across where this opening is. So the post-op course, the eye was quiet, the patient comfortable. He was 2060, as I said, with a hazy capsule. We waited to avoid CME and to allow things to quiet down, and he did extremely well. He was without correction, 2025 with 2020, of course, without any accommodative ability. And we put him in safety glasses, which if you have just one eye, it's a good idea. And it was progressive to give him back some near vision in that eye. 6 weeks post-YAG, he came back and he had an iritis, and he had admitted to a small dodgeball injury. Although he was wearing his safety glasses, it broke the safety glasses. His pupils seemed a little slightly larger over time. And the question was, what was going on with that lens? And could we leave it be? Because what I saw was the haptic had protruded, had become involved in the iris. So one of the principles here is that we really have to think on our feet and be on our toes, and you never know what's going to happen yet next, and how did that happen? So the thought was that this lens had become unstable due to the small trauma, and my goal then was to go in and actually posterior capture the lens through an enlarged posterior opening, which I would do with a vitrector. So I felt that even though we might be able to treat some of that inflammation, that this was not a sustainable situation. We decided to go back to surgery, and that was our plan. We quieted the eye with steroids before going in, another important principle, and you'll see what happens, which is kind of interesting. And Steve Charles may wish to comment, using a trocar system when the eye is totally sealed can be safe. A 30-degree approach to the sclera is optimal. I've overdone that here a bit in that I want to make a scleral tunnel, and you'll see the collar pop backwards, which tells me that I've not broken the floor or the ceiling of that tunnel. I want that to be self-sealing if at all possible. And it's the first maneuver before making any other incision, because we want that take some pressure to put that in. Now my goal was to go in and use the vitrector to try to enlarge that posterior capsulotomy in order to stabilize the lens. But as I begin to enlarge the space here, what you'll see is that I recognize that that lens is stable as can be. And the last thing I want to do is dislodge it. And you'll see that very soon. Of course, I like to keep irrigation anterior. I only will do a 1-port pars plana vitrectomy as an anterior segment surgeon. And so where this was before there were valved trocar systems, I'm putting viscoelastic in to explore, because that lens seems so stable that my original plan is not going to seem appropriate. So I have now a nice visual axis, and you'll see me sort of shake the eye in a moment here in order to see just how stable this thing is. And I'm looking and seeing that, my goodness, that is sneaked in place. So what am I going to do next? I'm obviously not going to, the lens is fine as far as the center, but I don't want that haptic to be involved in the iris. And so I'm releasing the haptic from its entanglement with the iris here. And and I'm going to do this little maneuver where I have to make a decision what to do with that haptic and how to properly tuck it or get it out of harm's way. You'll see here an interesting thing. It's so very stable, the lens doesn't move. So I decide to sacrifice that haptic and just eliminate that haptic from the situation to get it away from the iris, and naturally hold on to that and remove it nicely. Now I'm using my triescence, and I didn't see anything. So I'm bringing the pupil. I didn't see any vitreous with particulate identification. I've decided this diaphanous area of iris is just starting to get more and more taut. and make the pupil bigger. So I'm going to take it out of the angle there and make a nicer pupil and do this pupilloplasty to be able to have a better visual axis, not just for cosmesis, of course, but for to prevent diplopia. And we get that taken care of. And always your last maneuver, and I'm removing the OVD with a vitrector. And the last maneuver should always be to use the triescence. And I did use that vitrector. I guess here we go. And you'll see with that last maneuver, I was shocked to see there was actually vitreous forward. So I went back in and through the trocar, which is the last thing to remove, the trocar system, and did an anter-vitrectomy by a one-port pars plana approach with irrigation forward to keep the pressure anteriorly. And now we've removed all the protruding vitreous and proven that, and everything is sutured and secure. In removing that trocar system, we apply pressure right away. You might use actually the trocar itself and push even harder, but there was no bleb. And later on, we must do scleral depression to be sure that there's no incarceration and no tear. The patient did extremely well. Actually, even 2 weeks post-op was 20/20 post-amputation of this haptic, and ended up with a very beautiful cosmetic and functional outcome. Off all drops by 4 months, symmetric pressure with the other eye, although over follow-up about 4 to 5 years post-op, the pressure began to go up. And we always should expect that and anticipate that there can be a traumatic glaucoma that shows up late. He also decided he wanted to become an eye surgeon. So in summary, we want to avoid irrigation and turbulence when we really don't know what the anatomy looks like. We want to identify structures and slowly allow the various structures to be put back in the same place. We want to maintain the chamber at all times and keep the eye as normotensive as possible, never allowing hypotony or huge changes in pressure variations that can promote bleeding, particularly suprachoroidal hemorrhage. And compartmentalization is so very important, which is how we can use our various OVDs to great advantage, as Steve has shown us so beautifully ongoing. We want to expose trabecular meshwork to allow it to function, avoid cautery where possible, and prepare the patient for more than one surgery. So thank you for your attention. Hopefully this showed many aspects of how we want to approach these cases. Each one is individual, but if we keep these points in mind, we'll often have a wonderful outcome.
Thank you so much, Dr. Lisa, because these traumatic cases are so much like a Pandora's box, because you really don't know what you're going to be heading for. So I think number one rule is to prepare your patients very well in, before you start your first procedure only. And of course, about the expectations of the results. I just want to ask you one question, like in traumatic cases, would you not prefer to put the lens in the sulcus? I mean, like as a rule, do you think that's a better idea?
Well, we in the U.S. don't have a lens that actually fits the sulcus and stays there. You know, we no longer have the Star AQ series, which was 14 from haptic to haptic, 14 millimeters. They're too small, and the haptics lose their memory quite easily. So unless we can optic capture, I don't like or somehow secure the lens and not allow later an UGG syndrome from movement or finding whatever little opening there is. If we can't optic capture or don't want to suture to a sick iris, then we require a huge vitrectomy in order to scleral fixate. So I don't want to put it in the sulcus. I would have left this eye aphakic if I didn't feel I could sequester haptics properly in the back. And obviously the haptics did rotate to the point where they got out, you know, we had that nice V of anterior capsule, but just it not much below. It was split, and it did come out in that fashion. Now, had I put it, and so it came to the sulcus and then actually went into the iris. So no, I don't think that the sulcus is a very good place unless we can secure it, at least with the lenses that we have available in the US today that are not intended for sulcus. It's off-label to use them in the sulcus.
Thank you very much.
Lisa asked me to comment on the trocar cannula system use. Remember, trocar is what you replace cannula with. People always say it backwards. But the discussion she and I've had in the past is about post-cataract surgery when you decide to do an anterior vitrectomy through the pars plane, and I'm an advocate of that. And the insertion force of the trocar is much higher than an MBR blade. And so numerous people have ruptured the wound. They said, oh, my wound's self-sealing. No, it's not. I sutured it with a 10-0, not strong enough. So if you have an unsutured cataract wound or just a hydrate, that you've used hydration of the wound to close it, and you insert it, you can puncture the other side of the eye. You can with the trocar, and you can also cause an iris prolapse. So if you're intent on using a cannula, which is absolutely unnecessary in most of the anterior segment cases, because the design for it was the introduction and exchange of multiple instruments over time. You're going to put a vitrector in once and take it out. What's the point of having a cannula there? And so don't cause an iris prolapse. So don't believe your wound to be watertight without significant suturing. And I even recommend an X-type suture with an 8-0 if for some reason you want to use a trocar cannula system.
And of course, in this case, it was done secondarily. The patient had already healed the incision, so it was a reasonable choice at that point. Yes, there's controversy in that we're right at the wall of the eye, and we'll always have some prolapse of vitreous through the sclerotomy. And yet, I think that all the points that you make, Steve, are critical. Thank you.
Thank you very much. So thank you, Dr. Lisa. That was a wonderful overview of all traumatic cases and how we could sort of have any complication at any time. Thank you very much. So our next speaker is, we'll go over to Dr. Steve Arshner. Dr. Arshner has a special interest in cataract and refractive surgery, as we all know, specifically in simultaneous bilateral cataract surgery, SBCS. And he is known for his antibiotic prophylaxis for intraocular surgery. He's designed a lot of phaco machines, and his special interest in ophthalmic viscosurgical devices that we've all followed now, and to have safer intraocular cataract surgeries is what we are also advocating as such now. He's a recipient of the 2020 Outstanding Humanitarian Service Award. So congratulations on that, Dr. Arshner. And over to him, he'll be talking to us about moxifloxacin intracameral use and what is his insight about it.
Thank you very much. It's really an honor to be included in this esteemed faculty and listen to all these fantastic talks. So I've been interested in really trying to convince the world how we can decrease infections by using antibiotics. And I'm going to talk about that. My disclosures are here, but my real disclosure is this, that I favor bilateral cataract surgery and I like to use diluted Vigamox. And I'll explain to you why. And quite frankly, if a better drug comes out, I'm happy to change. So the first thing, we should look at all the ways we've done to prevent infections in surgery. And we all use preoperative betadine, except for the Swedes who use chlorhexidine. If you want to do that, don't use Hibitane, it's toxic to the cornea. Use the ones the Swedes use, which are diluted. We all do tight wound closure, intracameral antibiotics. And I'm going to talk about other ways of giving antibiotics that may or may not help as well. So the first thing I want to show you was a talk that was given by Lindsay Ongtone, who's from Saskatchewan in Canada. And he clearly showed that when we give preoperative topical antibiotics, they're only effective when they're given within the 2 hours or so before surgery. If you give topical antibiotics for a few days before surgery, all you do is you decrease the susceptible bacteria on the conjunctiva and allow resistant bacteria to grow, which doesn't really help our position. So now, at the current time, intracameral moxifloxacin is the most commonly used intracameral antibiotic in the world. I was the first to use this in 2004, and there have been numerous papers, the largest study, of course, being by Haripriya, Chang, and Ravindran, where they did 2 million eyes, and they showed how well it works. The only studies ever to not show that it works well were from Japan, where they used too low of a dose. So I've now done 10 or 12,000 cases, and I've had no problems doing it. It's an excellent method to do prophylaxis. So if we look at the drugs that we have to prevent postoperative infections, we start off with 5, and I grade the ones that are now either history or becoming history. The most recent one to become history is vancomycin, and that's because of the problem with HORV and the risk that we have with it. So I'll discuss the drugs and how we choose what's best for our patients. The first thing you have to understand is that time-dependent drugs are less effective than concentration or dose-dependent drugs. And that's because they have to stay in the eye for a longer period of time to have their effect, whereas with a dose-dependent drug, if you get a high enough dose in the eye at the time of surgery or shortly thereafter, you kill just about all the bacteria that are going to be at risk. So Paramontan and others have shown that if we give either cefuroxime 1 milligram or moxifloxacin 0.5 milligram into a human anterior chamber, they're completely safe. Those are the two drugs that are the biggest competitors now. So the three big ones that we were looking at in the past number of years were vancomycin, which we stopped using in Canada because they were making generics, and all of them were shown to cause TAS. And the rest of the world stopped using them because of HORB more recently. So we have cefuroxime, where the problem is really that enterococci can still grow. And if you give patients cefuroxime, the infections that do occur tend to be the enterococci, which are not easy to treat, and the patients don't do well. Moxifloxacin has been criticized because it's a dose-dependent drug, but we can achieve extremely high levels in the eye that overcome any resistance just about of any bacteria that we've ever seen in ophthalmology. So there are a number of issues on how we look at drugs. The first one is that if you do engineering, you immediately learn to analyze failures, because that's one of the big problems that we have. And if we apply failure analysis to infections, you find out that if an infection occurs with intracameral Vigamox, it's likely due to moxifloxacin-resistant coagulase negative Staphylococcus. But those are generally very sensitive to the usual endophthalmitis protocol we use, of vancomycin and tazotazine, because they're different drugs that work by different mechanisms. So the chance of being resistant to both of those two types of drugs is very low, and most of those cases get a good visual outcome. However, with cefuroxime, the problem is that if we get an infection, we're going to treat it with a drug similar to the ones that we treated to prevent the infection, and most likely the bacteria will be resistant, like enterococci, and the patients usually end up blind. But there was another issue that people are looking at comparing drugs. And for example, in Sweden, the Swedish National Database compared the outcomes of using intracameral moxifloxacin to cefuroxime. They showed that they actually had fewer infections with moxifloxacin, and they had enterococci with cefuroxime, but they showed that they had an excess of staph and streptococcus when they used moxifloxacin, but they used too low of dose. They used 0.2 milligrams. If you look at a paper by Libra and Matthews a number of years ago, they showed that to eliminate staph and Pseudomonas require maximum dose of moxifloxacin exceeding or equal to 0.5 milligrams. So the Swedes in that study obviously used too low of a dose. One of the studies I said before in the beginning, if you use too low of a dose, you don't get a very good result. Next issue. When we report MIC 90s, you have to look at how we report them, because every specialty in medicine has their own sort of standards of how you do things, and they don't often apply very well to what we're trying to do. So for time-dependent antibiotics like vancomycin and cefuroxime, what we do with them is we don't talk about the bacterial types that are absolutely resistant. So for vancomycin, gram-negatives are resistant. For cefuroxime, enterococci are. When we calculate MIC 90s, we don't include these bacteria. They're not covered. But with moxifloxacin, which kills everything at different doses, what we do with it is we say that the MIC is some number. But that MIC is going to include a few that are relatively resistant. All you have to do with moxifloxacin is increase the dose, which we do in the eye. It doesn't matter what the serum levels are that are resistant, because the amount we get in the eye is much higher. So when we compare them, the comparisons aren't fair when we report MIC 90s because of the bacteria we choose to include in that calculation. This is a study that was done in the BJO, which showed that in a meta-analysis of all infected cases, that the lowest infection rates were occurring with vancomycin and moxifloxacin, and it was about twice as high with cefuroxime. Now, so the current debate is, should we inject intracameral moxifloxacin either right from the bottle, where we give 0.1 mils of 500 micrograms per mil, or dilute it, where we use either my formula of 150 micrograms in 0.1 mil times 0.4 mils. The reason for the volume is that the volume of a newly aphakic or pseudophakic anterior chamber is 0.5 mils. So here you can exchange most of the chamber. Or the Kaiser recipe, which is used in the US, they now use 100 milligrams in 0.1 mil, and they try to inject 0.5 mil. The problem with this is, suppose you have a hyperope with a small anterior chamber, there isn't that much space to inject. And what happens is you don't end up getting 500 micrograms. And so they then are again at risk for getting infections from rare bacteria. Next problem, why do we ever want to inject 0.1 cc? Well, that came from retina surgeons who are trying to inject in closed eyes for endophthalmitis and don't have much space. It's not really a problem that we face as anterior segment surgeons, and I see no reason for us to adhere to giving 0.1 cc into an anterior chamber, which has much more volume, which we can exchange. And so I think it's far better to dilute it. And also, if you want to have enough to either seal the incision or put some in other places of the eye, make sure you get it all in, you're better off to have a little bit more because we're not so concerned with the volume. So a study by Shorstein and Gardner showed basically smaller injection volumes of a higher concentration of moxifloxacin resulted in less accuracy and less precision in delivered dose. Period. Simple. A good paper, very clear. That's exactly what they found out. Does anything around to back that up? Well, we did a study of all the bilateral cataract surgeons in the world, looking at over 125,000 eyes and the infection rates in doing surgery. And we found that the infection rate was very, very low, 1 in 17,000 in giving intracameral antibiotics. This is supported largely by the moxifloxacin group, of which a lot of the cases, about half were mine, where I was using this large volume injection and got very few infections. Recently, the group in Quebec City, the entire city converted to doing bilateral cataract surgery and converted to using my formula for intracameral moxifloxacin. And in their bilateral and unilateral cases over 5 years, they calculated their infection rate has fallen from 1 in 1,000 to 1 in 14,500, similar to the infection rate we found in the bilateral study. And these are the two studies in the world with the lowest infection rates. Also, Asena did a study in rabbits and found out that when you inject 0.1 cc in the first short time, half an hour, over 90% of the injected antibiotic into the anterior chamber can leak out, despite their paper discussing the efforts they made to make sure very little leaked out. If some leaks out, you don't get much in the eye. So we did another few papers. We just published 3 papers in a series trying to look at what we can do to prevent infections. And the first one was to discuss openly the methods of creating a mathematical model to calculate what the doses of drugs we need are. And we could show this graph. These lines horizontally are the lines here of the regular bacteria we're trying to kill. And these are the resistance levels. This is the 10 times that level. And this is then the 2 most resistant bacteria we've ever heard of in the world compared to moxifloxacin. This is a dose of the decline of moxifloxacin in the eye over time. So we took that basic graph, and then we did another paper, and we tried to include other antibiotics, and we tried to shift them for dose dependence of moxifloxacin and time dependence of vancomycin and cefuroxime. It's very nice we can have only one line for both vanco and cefuroxime because they happen to be injected in the same dose in the eye, and they happen to have the identical MIC. What we find is the gap here between the level of drug we achieve and the target bacteria is twice as high if you look at these double arrowed lines for moxifloxacin in blue compared to the other 2 drugs in red. And these red circles tell you about how long the drug will be effective for. And we find out that it's effective for twice as long if we use moxifloxacin compared to vancomycin or cefuroxime. So then we want to look and see, well, if we can do that well with intracameral antibiotics, is there any benefit of topical drops or oral antibiotics? And you can do all these things mathematically where you can't go and take a patient and keep sampling their anterior chamber every hour or 2 postoperatively. So this graph tells you how much moxifloxacin you get in the eye if you give it in this orange line every hour. And you get basically a level 4 times the mutant prevention concentration of the most common bacteria that you see in endophthalmitis, but you don't get a level high enough to kill the 2 most resistant strains. So now if we look at not every hour, but what we might use clinically, 6 times a day in the red or 4 times a day in the orange, we find that these 2 levels of moxifloxacin hang around the mutant prevention concentration, adequate to kill the usual bacteria we get in infections, but not adequate to kill the 2 most resistant bacteria ever reported in endophthalmitis. So if we give topical moxifloxacin drops for, let's say, 6 times a day postoperatively, for as long as we keep giving those drops, we're going to have a level of antibiotic in the eye sufficient to kill most bacteria, but not all. But when we stop the drops, we drop off, and within 24 hours or longer, we no longer have an effective level of antibiotic in the eye. If we try to give it topically, the only time we get a sufficient level to make a difference is right around surgery. And afterwards, if we stretch it out, because we have a reserve in our body, you see that when you give the oral antibiotic, either this orange line with the intracameral or the red line without the intracameral, we end up with a level that's higher than just giving intracameral after, let's say, 2 days or so. What that tells you is the supplemental oral antibiotics are only valuable if the patient walks in after a car accident or a systemic infection, and we're preventing endogenous spread. It makes no difference in terms of just doing the cataract surgery without another problem in the patient at the time. So then we wanted to look and see if we have evidence to support all these contentions. And it turns out we looked at all the patients in the last 50 years that had bilateral simultaneous post-op endophthalmitis. There have been 9 cases like that. And only 2 of those cases followed the guidelines of the International Society of Bilateral Cataract Surgeons and how to do safe bilateral cataract surgery. One of them was a 79-year-old male from Quebec City who received 0.1 mil undiluted moxifloxacin and got an infection 6 days later with staph epidermidis, the usual resistant strains that we might get. And then the other one was a 93-year-old female from a chronic care home in Sweden who underwent successful surgery and then 2 weeks later got again an infection with a resistant staphylococcal organism. And these are because I strongly believe when you inject 0.1 cc, you don't get enough in the eye in many cases. And if you have a patient that's immunodeficient, you're likely to get an infection. And I think both of these 2 cases show us that you want to get at least 0.5 milligram in the eye at surgery, or else if the patient is susceptible, they may get an unusual infection. Here's how you make it up. It's very simple. You take Alcons or Sandoz, a safe generic copy, and you put the whole thing in a syringe, add 7 cc's of BSS. Here you have a syringe, put a bit on each tray and give it to the patient. It's very, very easy. We have some moxifloxacin we can buy, especially in India. You have Oramox and you have Forquin PFS. They're all designed to give the 0.1 cc's and get 0.5 milligram. And this one, the Oramox, is multiple use. It has enough for 4 or 5 patients. And the other one is for single use. But no one makes the diluted one available anywhere as far as I know. So in summary, moxifloxacin, from all the data we could collect, appears to be the safest and most effective prophylactic antibiotic in the world. You have to give at least 0.5 milligrams to kill all the bacteria. And I think this lower concentration, higher volume system works best. Topical and oral supplements do not make much difference to most cases. Topicals protect somewhat if a patient gets a wound leak post-op. Systemic ones only protect from endogenous spread. Thank you very much.
Thank you very much, Dr. Steve Arshner.
Professor Dr. Steve Arshner, a very good presentation. One quick question. Hospitals tend to have a series of TAS syndromes. And when they have that, what's the protocol they should follow? Because that makes all the difference in how quickly you can identify the cause and resolve it. And after you, I request Dr. Peter Kaiser, Dr. Steve Charles to give it the word also. Thank you.
Well, TAS is a difficult problem. And one of the things that we stressed in our bilateral surgical society is that the first rule you should have in every operating room is you don't change anything until you have a meeting of the nurses, the staff, the pharmacology people, and all the surgeons to discuss what the new thing you want to bring in is and make sure that it's safe. And then if you do get TAS, you have to go every single thing you do, every single little step, and find out what it was. We had a very unusual series of TAS in one hospital in Canada where one ophthalmologist, for some unknown reason, decided that he was going to, instead of using an injector for the lenses, he was going to roll the lenses in his fingers and put them in through the incision rolled by his fingers. And of course, the plastic from the glove got on the lens and caused TAS. Who would ever imagine someone would do that? But somebody does. So the bottom line for TAS is don't do anything that you haven't checked out very carefully. Don't use any devices or drugs that you haven't checked out carefully, and then you probably won't get TAS. And if you get it, check every little crazy step you do.
Dr. Charles, your comments?
I certainly agree with what Steve said. I've participated in these discussions at the ASCRS with the sponsorship of the International Study in Moxifloxacin.
And never had an endophthalmitis after following Steve's lead with every case using Moxie.
Dr. Kaiser?
I completely agree. I mean, understand that what we use for, especially for endophthalmitis, is completely off-label anyhow. And in this case here, the sort of data that's being looked at for Moxie has been very good. The dosing appears to be, done in a rational manner. I completely agree about why we use 0.1. And for everything in ophthalmology, it's a matter of somebody moving forward and really testing it carefully. It's sort of like the use of Avastin worldwide. We kind of guessed. We guessed on a dose, and we changed the world. And that's how things move forward. So I agree. This is absolutely makes sense and appears to work very well.
Thank you.
Thank you very much.
Can I ask Peter a question? One of the things that annoys me in Canada is all of the on and off label stuff in the US. We all are doctors, and everything we do tells us that we're responsible for what we do. My humble opinion with the US, who cares if it's on or off label? Almost everything we do pharmacologically is wildly off label. And you go to every meeting and you can't announce if it's this or anything off label. You can't say this, can't say that. I think it's ridiculous. Of course it's off label.
It's a medical legal issue, in the US. And that's the only problem is that, we stick our necks out here, and that's how it is. And yeah.
Well,
but your neck is stuck out anyway.
Is pricing. So Avastin, for instance, bevacizumab, if this is a CME event, is basically off-label, and we can administer it for about $50, $100. It's US dollars, so it's cheap. Right now, there's a study going on in the US for a on-label, so a approved Avastin by Outlook Therapeutics. So it's basically a Avastin biosimilar that they're testing against Lucentis, and the phase 3-1 was positive. The second, I'm sure, is going to be. And then we have an on-label approved Avastin. The issue with that is the price will probably go from $50, $100 to maybe $500, $600. And then you see the issue with that, right? So I agree with you. Off-label is just a medical issue. It has nothing to do with patient care. And unfortunately, in the US, it does have to do with pricing.
But you're equally liable. No matter what you do.
I'm sorry, with respect to the outlook, and there are other concerns about that. 12-week Lucentis, which is basically a 4-week drug, in a superiority trial, it's a ridiculous trial. And I've heard people say, that they can use a prefilled syringe. Well, Macugen had a patent on a prefilled syringe that prevented Genentech or Regeneron from using it for 10 years. And Novartis has a very strong patent, and they've sued Regeneron over a prefilled syringe. So the idea they can just hand wave and make the patent on prefilled syringes go away makes no sense. And the last point is that biosimilars did not drive the closing of the prohibition of compounding pharmacies making something. It has to be an identical molecule, and that's a one-on-one discussion I had with Wiley Chambers.
You're 100% right, Steve. I think to me the study design is suspect, and one of the ways that Outlook, at least in the United States, is trying to get around it is the generic bill that Steve is talking about. There's a bill in the United States that specifically says if there's a generic that's on label, that's approved, you can no longer compound a medication. But in the United States, in the FDA registry, specifically biosimilars, and specifically in the registry, Avastin is called out. If there's an on-label version, you can still compound it. So at least in the US, we'll still be able to use it.
Thank you very much for lovely discussion and a very informative discussion for us in India as well. I'd like to call upon the last speaker of the Super 6 session. He's the first Indian ophthalmologist to get the American Academy of Ophthalmology's Lifetime Honor Award. He's a nationally, internationally acclaimed for his work on the field of ophthalmic plastic surgery and ocular oncology. He's counted among the top 2% of the world's researchers and among the top 10 Indian ophthalmologists in research. Dr. Santosh Hunawar, sir, a pleasure to have you on board.
Thank you so much. Thank you for making me part of this session. I'll just share the screen. Is my screen visible?
Yes, it's visible, sir.
Okay. Shifting gears, I'll be talking about some of the recent advances in ocular oncology. I'll be talking about imaging, target therapy, minimum intervention, and multimodal treatment in some of the ocular surface tumors, eyelid tumors, and orbital tumors. Imaging has revolutionized the diagnosis and management of ocular surface tumors. There is no diagnostic dilemma in the pictures that I show, but if you were to have a diagnostic dilemma between a nevus and a melanoma, you have a good clinical checklist. But still, if you have a confounding clinical situation, then you fall back on anterior segment imaging. Microcysts, as you see here, or macrocysts, are supposed to be diagnostic of a nevus. Nevus is spongy as opposed to melanoma, which is solid. A clinical application of this use of anterior segment imaging is in a teenager child of a physician who comes to you with a fleshy pink lesion with a feeder vessel and intrinsic vascularity reaching the limbal barrier and extending just a little bit onto the cornea. When you do anterior segment imaging, you find that there are microcysts confirming the diagnosis that it's an amelanotic nevus and nothing dangerous. This was a patient who always had a nevus here and it started growing bigger. And when we did imaging, we found a solid lesion which conforms to melanoma and a cystic lesion, which is still a nevus. And that is the zone of transition between the nevus and a melanoma. So if you have a nevus that is growing, you can do imaging to see whether this lesion that is growing is actually solid, possibly a melanoma. And if it continues to be cystic, then it's just a nevus that is growing bigger. In ocular surface squamous neoplasia, we have keratin, abnormal vascularity, and rose Bengal stain, which together are highly sensitive and specific to the diagnosis with histopathology as the gold standard. If you have a clinically confounding situation, you can again use anterior segment OCT. Hyperplastic, hyperreflective corneal epithelium, which ends abruptly with a snout, is diagnostic of OSSN. It can also be used to diagnose the depth of the lesion. In this patient, the lesion is confined to the conjunctiva and the tenons is all free. So your plane of dissection would be episcleral. In this corneal OSSN, we find that the corneal stroma is splayed here as opposed to normal corneal thickness here, confirming that the cornea is full thickness involved. So this patient would either need a penetrating keratoplasty or plaque brachytherapy. You can even diagnose anterior segment invasion and prepare the patient for worse prognosis. Now, here is a situation where we can use Ocd angiography to look at the conjunctival vessels in various layers. Clinical application of this technique is probably in detecting early recurrences following conservative treatment, which is topical therapy. Now, going on to topical therapy, we had chemotherapy, which was mitomycin and 5-fluorouracil. Now we have interferon, which is immunotherapy. Immunotherapy can be used for complete tumor control. There's also a concept of immunoreduction, where you can reduce the size of the tumor so that you can do conservative surgery, and immunomodulation to prevent local tumor recurrence in high-risk individuals. This is a small tumor which can be completely resolved in about 6 to 8 weeks with topical therapy. This was a patient with small recurrence, again resolved with about 8 weeks of topical interferon. Typical application is in corneal OSSN, where if you were to do a biopsy, as a cornea surgeon here did, rest of the tumor resolved with topical therapy, and that's the exact area where biopsy was done, that a residual corneal scar. So corneal OSSN with pupillary axis involvement are typical indications for topical therapy. This is a patient with xeroderma pigmentosum with a graft. This is the third graft. The prior two grafts had failed, and unfortunately, he has developed a tumor right at the graft-host junction. If you were to do surgery, you might tip the balance in favor of a graft rejection or a failure. As opposed to that, topical therapy resolves the lesion and keeps the graft clear. 6 clock hours of limbal involvement would mean that there might be limbal stem cell deficiency following excision, but interferon provides scarless healing without causing conjunctivalization of the cornea. It works very well in diffuse tumors as well. This is a concept of immunoreduction, where if you begin with a larger tumors as this, you can reduce the size of the tumor to a small residual, that is the invasive component, whereas carcinoma in situ dysplasia gets resolved with topical therapy. So we are just left with this smaller tumor to deal with following immunoreduction. Use of injection interferon is common in patients who have diffuse ocular surface squamous neoplasia involving even the palpebral conjunctiva. But 5 years ago, we would exenterate such patients because these are typically unresectable. Now with injection interferon and combination of topical interferon, these patients have preserved eye and vision. This happens in about 50 to 60% of patients. About 40 to 50% of patients still would need orbital exenteration. Surgery has a protocol, excision with tumor-free margins, etc. But when you really want to judge the depth of excision, then you can use intraoperative OCT, which correlates well with histopathology. A newer technique of primary simple limbal epithelial transplantation can be used if you have an extensive tumor to resect, so that you can resurface the ocular, repopulate the ocular surface. And beyond surgery, if a patient has limited anterior segment invasion or scleral invasion, these are typically unresectable and were enucleated earlier. Now we have brachytherapy with ruthenium or iodine. This is a patient after limited excision, preservation of the tectonic integrity of the eye. We perform secondary plaque brachytherapy after confirming on histopathology the extent of scleral base involvement, and that resolves well. This is again a patient with secondary plaque brachytherapy with preserved eye and vision. In patients who have a cornea that is precarious, which is already partially melted, and you would want to preserve the eye for some valid reason, then you can use primary plaque brachytherapy. Dosage calculation of this procedure has been sorted out with 3D conformal technique, and you can have nice results with primary plaque brachytherapy. This is again a situation where primary plaque brachytherapy has been performed with good results. Now with melanoma, if you already know that sclera is involved, again, you can use primary plaque brachytherapy, and that works well with eye preservation rates of about 80%. What's new is that we have a new plaque that is designed in India currently, which has made it much less expensive as compared to imported plaques. Vaporization of conjunctival tumors is something relatively new, where if you have a lymphangioma, you have an option of surgical excision versus injection of bleomycin. Short of that, you can vaporize these using carbon dioxide laser or RF electrode, and you can resurface the conjunctiva using amniotic membrane with good results. This is one more patient with extensive lymphangioma vaporized. So this is a patient with divided nevus or a kissing nevus, where surgical excision can be challenging because of reconstruction that is involved. Here again, we can vaporize these lesions in stages, and actually you can see that the eyelashes grow back after about 6 weeks, thus preserving cosmosis. This is a close-up picture showing the eyelashes actually having grown back without any residual lesion. Target therapy for ocular surface lesions we have for lymphoma, where the conjunctival component, which is predominant, can be excised, but if there is a equatorial extension slightly posterior into the orbit, then excision becomes difficult, and the only option we have is radiation for such patients. Short of that, we can inject rituximab 5 milligram per ml. There's an off-label use of rituximab periocularly, can help resolve the situation. For conjunctival melanoma, we have worked out the mutational spectrum and the target agent, and there are increasing reports in the literature which have used this particular target therapy for regional lymph node metastasis with consequent resolution of the ocular lesion as well. Nivolumab is one such medication, and we had an occasion recently to use it for a patient who had regional lymph node metastasis, and he has ocular surface recurrence as well. 3 months later, his ocular surface lesions completely resolved, opening up a window of opportunity for use of target therapy for conjunctival neoplasia. Target therapy for eyelid tumors is with Erivedge or Vismodegib, Sonidegib, which is used for Golin-Gott syndrome. It can also be used to reduce the size of the tumor in inoperable patients so that they remain comfortable. And for sebaceous gland carcinoma closer home, we have chemotherapy to reduce the size of the tumor so that it becomes inoperable with conservation of the eye. You can see dramatic results after 3 cycles of chemotherapy. What is left is eminently excisable. This is a patient with lacrimal sac sebaceous gland carcinoma, a very rare variant where following incisional biopsy, we perform multimodal technique with preservation of eye and vision. Orbital exentration has been traditionally used for many orbital malignancies or intraocular malignancies with orbital extension, but it is not so effective. When you look at the results, you find very high death rates. So we have begun using multimodal therapy, which is a combination of surgery, radiation, and chemotherapy. This is a child with retinoblastoma, unfortunate, where there is orbital extension as well as extension to the superior orbital fissure and the cavernous sinus. Now, following neoadjuvant chemotherapy, what is left is the superior orbital fissure amenable to radiation. Of course, the child would need enucleation. This situation with optic nerve involvement has been resolved with neoadjuvant chemotherapy. Now the child is up for enucleation. What is striking in these patients is that we are able to preserve cosmesis without having to do exentration, just an enucleation. On completion of multimodal treatment, these patients are able to use a custom ocular prosthesis. In rhabdomyosarcoma, we can preserve the extraocular muscle. This patient has a tumor around the inferior rectus muscle, so we can leave a wedge of the tumor around the inferior rectus and resect the residual. That's the wedge of the tumor that's been left behind. The rest of the tumor has been resected. And following stereotactic radiation, they can preserve their ocular motility and don't have squint and amblyopia. For patients who would anyway need orbital exentration, we can minimize the morbidity by using neoadjuvant chemotherapy and then do a safe exentration so that we can preserve cosmesis. For adenoid cystic carcinoma with bone extension, we don't excise the bone and do orbitectomy. Instead, we use conservative therapy where there is multimodal treatment, en bloc excision of the tumor. Bone actually remodels itself, as evidenced by this child again, where bone has nicely remodeled with preservation of eye and vision. For recurrent complicated cases, we can deliver radiation to the bed of the tumor by using afterloaded brachytherapy technique using iridium-192. With all these techniques, we have much higher survival as compared to what we used to have 5 or 10 years ago. So in conclusion, I would say that there are rapid new strides and paradigm changes in ocular oncology with much better outcomes. Thank you so much.
Thank you very much, Dr. Santosh Navasa, for a lovely talk and very well managed cases. We were really learning a lot with your talk as well. And like to conclude, but Dr. Arun, like to conclude the session, please.
I'd like to thank all of faculty members. It's been an honor to have all of you take time off. I know some of you were sitting in North America very early on the Sunday. We appreciate that you took the time off. Having Steve Charles, Dr. Kaiser, Dr. Arshner, Dr. Santosh, and Dr. Lisa Arbiza is no mean feat. You have been very kind to us, and we hope to do scientific research together. I would now request you all to put on your best smile so that Dr. Aditya and Dr. Saiman can take a nice screenshot with Dr. Weber, and we will then use this and send it a copy to you. So please go right up to your molars with a smile. Thank you very much. So we'll now move on to the next session. I'll request Dr. Weber to continue with the second session. And you're welcome to stay on and hear the other speakers. Now we'll be doing shorter duration talks on case reports. Dr. Peter Kaiser, thank you very much for joining us.
Thank you very much for a lovely session.
And you're all invited to India. We'll be hosted by Team Arunodaya. Whenever you decide to come, you'll be our guests. We will host you and take you around and show you our forts, our rivers, and our beaches. So please pack your bags and just wait for the COVID to get over and come over.
So the next session is the fantastic session, and I'd like to call the first speaker, Dr. Hudson Nakamura. He's a professor of Vitretina at the Eye Bank Foundation in Guiana, Brazil. He's also the founder of Retinosum, a channel which celebrates and brings together retina specialists all across the globe to share knowledge and interact with each other. Dr. Hudson.
Yep. Thank you very much for having me. Can you see my screen?
Yes, we can see your screen.
And I'm going to show you a technique that I've been using a lot for macular holes, especially large macular holes. So I will start the video here. Just a second. I guess this video is a little large because actually this is a 30, it's a large video. I'm getting this, I thought that could probably happen. So I'm showing the less gigabytes version here. So we are gonna talk about this large macular hole surgery. And what I like to present, what is that?
We can't see your screen. Please share screen.
Okay, just a second again. Can you see it now?
Yes.
Yeah, now perfect. So this technique for large macular hole, I like doing that because we actually have perfluorocarbon liquid helping us to do the peel. So you see here a very large macular hole. And we start the surgery. The patient is pseudophakic. And what is most important is to see what we're doing. And so after a core and peripheral vitrectomy, in this case, we perform this fluid exchange. And now I'm using the macular lens. And so you see here the macular hole. And so I already inserted perfluorocarbon. So perfluorocarbon, what is the main function of perfluorocarbon? Is to help me lift these pieces of internal limiting membrane without actually damaging the retina and without having them fall apart. And with this technique, the weight of perfluorocarbon liquid helps me insert in this stuffing technique the pieces of internal limiting membrane inside the hole. So you get it. And what is interesting is that when you pull on the internal limiting membrane, the internal limiting membrane does not escape because the perfluorocarbon is actually forcing it down. So it's a very cool technique. Of course, you're going to be seeing during the video that some pitfalls may happen. You have to be very careful and with very slow movements. And after the exchange that you do, whether you are planning to use air, gas, or silicone oil, and in this case, I'm going to be using air and gas for the sake of surgery for macular hole, and that happens sometimes you could lose these internal limiting membranes. So when you, I'm trying to relieve here all tractions around the macular hole. As you see, they are very attached. But if they escape off the forceps, and this is a different forceps, as you see, it's a bend in one of the blades, and it's straight in the other. So you pull on the internal limiting membrane, and it detaches, and then you have more control over the membrane to insert it inside the macular hole. As you see here, I'm pulling here around the hole and being extra careful not to damage any structure after the internal limiting membrane. And all the time, the perfluorocarbon liquid is helping me with that task. And as you see here, I could put all the stuff in the hole, into the hole. And we have this brilliant blue, and actually this stains the internal limiting membrane very well. And you see here, still you have the perfluorocarbon liquid there. And if I would do that without the perfluorocarbon liquid, but that helps so much. And after this, you see the where did the ILM go? So it escaped off the hole. So what to do? We cannot just stop and keep doing the surgery as if it was the regular way. So it's not difficult to put more perfluorocarbon liquid, as I did it here. I inserted more perfluorocarbon liquid, and now I'm getting more of the internal limiting membrane. I'm actually doing the same thing. So as you see here, moving around with the internal limiting membrane, I'm going to go one way and get back to the other way and put the membrane just right inside the hole. So we did the same thing. And now we have to be extra careful. So I want to remove all perfluorocarbon liquid. I'll start the air fluid exchange right now with the perfluorocarbon in. Of course, we cannot leave any bubble. And with this very slow, I usually have 15 millimeters of the pressure there going on for not causing any turbulence. And you remove all the perfluorocarbon liquid, and the internal limiting membrane is there. Very slow up to the end of the surgery. And I'm using now this macular lens to see actually after I remove the instruments out of the eye, if the internal limiting membrane is still there. So I'm going to use this macular lens, and it is there. So even though we started and the membrane escaped off the hole, the main thing here is not to give it up and to keep going on until you have what you wanted to do, is the stuffing technique for the large macular hole. Thank you very much.
Thank you very much, Dr. Hudson, for an interesting surgery. I'd like to take Professor Steve Charles' opinion on how does he save his ILM flaps. Free ILM flaps, how do you prevent them from dislodgement, sir?
I rarely use free ILM flaps. I do wide peeling for holes that are in the 500 to 600 hole. I do wide peeling all the way to the arcades. And as Tamara Mahmood has instructed us, to peel particularly temporally, because the retina is kind of staked down, if you will, by the optic nerve head. So you don't have as much, you're at higher risk to make retinal breaks there. So if it gets larger than that, then I use the macular patch graft technique, which Tamer developed, and I changed to a PFO method where you leave the PFO in. So I reserve the use of ILM flaps for optic nerve excavation syndromes, optic pits, not for large holes, because you get better visual outcomes with the two methods I described.
Thank you very much. I'd like to move on to the next presenter, Dr. Jorge Mitri from Hospital Sao Paulo, Brazil, and he's the former president of the Brazilian Vitreoretinal Society. So, your presentation, please.
Hi, Dr. Seth. Thank you very much to participate in this very important meeting. And I would like to present my case. Can you see it?
We can't see your slides.
Can you see it? No, not yet.
No. Please share screen.
One moment. Every screen.
We can see your desktop.
Yeah.
Yes, now we can see the video.
Now you see?
Yes.
Yeah?
Yes.
Okay. Thank you very much, Dr. Seth. I'm very proud to participate in this very important Congress. I would like to show you a case of retina fold surgery. And it's a 60-year-old female, and she complained of a decrease of the vision 2 weeks ago. The vision acuity of this eye is counting finger 2 meters. And she had a big temporal detachment with macular off. And I submitted her to a vitrectomy and a buccal and a gas change and a laser. And oriental to have one pronal head position for 4 days. So after the surgery in the 10p post-op, you can see a big fold exactly over the macula in the left photograph, and the rest of the bubble of the gas. So one question: why appear this fold exactly over the macula from the disc to the periphery? You see, here in the left side you can see the buccal, the scar of the laser, and the big folder exactly over the macula. So this is the OCT. You see the retinal detachment in the folder, and the folder, exactly the same folder. And the patient is not so bad. She's okay. But I decided to do another surgery, and I would discuss with all of you what the best approach for this surgery. What caused the retina fold? This is the questions. What the best approach? Observation, waiting, or surgery? The surgery now, and what technique? Use the tunnel brush, redetach the retina, injecting subretinal fluid, attach the retina, or leave it detached at the end of the surgery. This is some question that I did. If you want to discuss now, or I can show the end of the surgery.
I have a couple of comments, if I could. What causes it usually is people that do fluid air exchange before they do endo drainage of subretinal fluid. So if you always initiate endo drainage first and never stop it during fluid air exchange, then you don't create the macular folds. But in terms of dealing with it, there's a method I learned from a doctor in Spain who uses it for hypotony maculopathy, and that is if you simply peel the ILM and do nothing else, no subretinal injection, no PFO, no gas, you simply peel the ILM, the fold will slowly go away. And the reason for that is the ILM is elastic, and once anything distorts the macula, if you don't peel the ILM, it won't go back where it was.
I agree with Steve. You know, this is oftentimes occurs if you pull the buccal up while you have PFO and there's fluid still. So really, it's a matter of basically making a change when there's still subretinal fluid present. That's when you get the fold. In terms of getting rid of it, certainly peeling ILM is reasonable. Relaxing the buccal a little bit is also reasonable, or just putting a subretinal bleb and teasing it out. The subretinal bleb is a little bit more invasive, but certainly works also.
The problem, if you see the membrane, doctor, you see that the fold go until over the buccal. It's go to the periphery.
Yeah, exactly. And that's oftentimes what happens is as you pull up the buccal, that's where the fold forms. That's why relaxing the buccal a little bit and then basically massaging it out with the subretinal bleb works.
Yeah.
But you don't want to do this too late. I think the key feature of this is don't wait. When you see this, don't pray that it's going to get better by itself. It won't. You need to go back soon before, as Steve said, the retina develops memory, so to speak. So you have to go pretty soon once you recognize it.
Yeah. Do you think that this fold can disappear by itself?
Very unlikely.
Yeah.
Professor Kaiser, is there any posture that you like to give such patients initially to prevent a fold from happening?
Yeah, I mean, this is the key thing. Like if you're going to leave subretinal fluid in the eye and use like a bubble to reattach the retina, like a pneumatic buccal, for instance, you have to steamroll the patient in the recovery room to avoid this. Basically, you reattach the fovea first and then slowly steamroll with the bubble in the eye the fluid out of the break. So you see this more frequently in just buccal, pneumatic buckles. So where they have a buccal and a gas bubble. where the patient just was put into a position quickly. But if you steamroll in the post-op recovery, you're less likely to see this.
Yeah. I will show you the result, and after that, I don't do this surgery. I did another one, and I will show you. This is the post-operatory. You can see in the color photograph a little bleeding in the vascular brain, and the fold is completely disappeared. 7 days. This is 7 days after the surgery that I did. And you see the buccal in the left photograph. It's continued in the same place. And this patient now is very happy. I will show you the surgery. I just injected with a 41 gauge cannula with silicone syringe. I did a bubble exactly under the retina in the bubble, in the fold. So after that, I did a fluid gas exchange and put the patient in the prone position for some hours. This is the surgery. You can see here the fold and the injection. I remove the rest of the vitreous and leave the eyes in in low pressure. I leave the eye in the low pressure and did this bubble you can see here, a big bubble. So I detach all the macula and the periphery of until the vascular temporal vascular brain. So, and this after the air fluid exchange, and this is the surgery. It's all.
Thank you very much, Dr. Mitri. What a great discussion here. And as we did understand, Dr. Steve and Dr. Peter told us also, and as how you attended the surgery. So we've got different ways of milking the cat. And so we learned a lot. Thank you so much.
Thank you very much, Dr. Fit.
Thank you. I'd like to go to the next presenter, Dr. Marcelo. He is the president of Bolivian Vitreoretinal Society, and he is the vitreoretinal consultant at the Instituto Privado de Ophthalmologia in Bolivia. Dr. Marcelo. Yeah.
Thank you very much. I can't share my screen, please.
Dr. George, can you please unshare?
Yeah. One moment, please. It's not working.
No problem. You can just close Zoom. I think that should also work.
Okay, let me close the Zoom and open again. One moment.
Yeah.
It's okay now?
Yeah, just leave me. Yeah, perfect. Thank you.
Okay. Can you see my screen?
Yes, we can see your screen.
Okay. So I'm going to talk about pediatric ocular trauma. My case is about a female 20 months old who suffered an accident with a glass cap, presenting horizontal laceration of 22 millimeters approx, loss of vitreous and iris, hypotony, and a structural loss of the eyeball. So this was a tough case. I'm going to show the first surgery. It was a primary surgery for repairing the structural damage of the globe. In the first surgery, we can see a structural damage to the eyeball, loss of vitreous, iris, and crystalline, in addition to a wide horizontal one that involves the square. So as you can see, we are working with repairing that injury and also repairing the lacerations in the skin, in the eyelids. To pass then to the second surgery that I'm going to show you. Finishing the first, it took at least 15 days to perform the second surgery. So here's the second surgery. We put first the trocars. We need good visualization. That's why I'm removing the corneal epithelium. And what we found was a giant tear nasally with small holes around it. We perform first the vitrectomy. And then it doesn't seem too hard to the retina. It wasn't that bad, so we put some laser. Once we finish removing the subretinal fluid, and at least like 1 month after the second surgery, the patient came, the girl was playing in the park and fell, and we found the choroidal there. It was okay. I mean, the retina at the post-op was really attached. But 1 month later, a patient came to my office and I found retinal detachment, read it with Pvr, a lot of complication. What we usually do in these traumatic patients is using methotrexate, 1 dose of 1,200 every weekend, but this patient didn't come to the injection, and we noticed that the retina was really detached with Pvr. You can see we are removing the fluid, the subretinal fluid. So we needed to do a retinectomy. What we did was a new technique called TRT, Tetris retinectomy technique. Is like the game Tetris. So we perform this multivectorial cuts to avoid traction, in inflammatory traction in the future, and to skip a new redetachment. We use triamcinolone also, and then we finish with putting some silicone oil at the end. We are doing this intravitreal injection of methotrexate every week, and by now the retina is attached. And I like to mention these cases, these tough cases, traumatic cases, because sometimes this happen very quickly, this detachment with complications. Thank you very much.
Great technique, Marcelo. I would like to ask you about the methotrexate, how you use that. It's very interesting, and we have far more PVR cases, especially when we see these traumas like that. So what are your dosing and issues on that?
We usually, what we do is 100 to 2,000 every month, once every week, for a month, and then every 15 days we maintain the dose, and finally 3 months we use 400, as it mentioned in some papers. So for traumatic and for kids, it's very useful to avoid redetachment in these complicated cases. When it comes to PVR in a adult person, we use similar dose the first 15 days, and then we change to 400 micrograms. We maintain the dose every for at least 6 months. That it mentioned. I forgot to mention that.
Professor Charles, what is your opinion on methotrexate in the use of PVR?
I'm sorry, who were you asking?
You, sir. I'm asking you, sir, what is your opinion on using methotrexate in PVR cases?
Dean Elliott is the guy that really put this on the map at Mass Eye Infirmary at Harvard, and he was in my session at the American Academy of Ophthalmology Retinal Specialty Day, and specifically said, when asked that question, we will wait to see if the data shows that it works. So I'm waiting to see if the data shows it works.
Perfect. And in pediatric retinal detachments, what is your opinion on using the medium-term PFO that you normally advise? Is that also a good option?
Absolutely. I use that frequently I use it for all inferior detachments. I basically eliminated scleral buckling a number of years ago, and because of the refractive issues and strabismus and pain and ocular surface disorder, etc. And so with inferior detachments, inferior giant breaks, temporal and nasal giant breaks, it works great. Of course, you can't leave the PFO in for 2 weeks for a superior giant break. Simply doesn't work. So you have to exchange it for the superior ones. But you eliminate the positioning problems. You must use a full fill. Then you can't do a partial fill. There's no advantage to it, and it simply doesn't work as well. So fill it all the way to the top and put them on topical difluprednate. And I'm very happy with that. And I've done well over 1,000 cases.
Thank you. Professor Kaiser, any word from you regarding management of pediatric retinal detachments?
Well, I mean, I think the key is to get the hyaloid up. I see a lot of re-ops that I have to do in this area, and oftentimes it's because they didn't peel the hyaloid, which is obviously difficult to elevate, especially in a setting of a retinal detachment and post-trauma. But it's vital to perform it. Whether leaving PFO in or not, that remains to be seen. And in methotrexate, I agree with Steve. I mean, the results so far in limited case reports have been good, but a randomized phase 3 clinical study is ongoing as we speak to see if it really works or not.
With respect to Peter's comment about the hyaloid, which of course is correct, one of the advantages of medium-term PFO is that the initial procedure, if the PVD isn't created easily, instead of pulling on it hard enough to make a giant break, particularly in a trauma setting where you might even have retinal traumatic necrosis, the PFO will slowly create a PVD over the ensuing 2 weeks. And when you go back at the 2-week mark to take the PFO out, you can get the rest of the vitreous then. So the slow, gentle PVD creation is a nice attribute of medium-term PFO.
Thank you.
Can we call our next speaker now?
Yes, please. Go ahead. Thank you. Thank you, Dr. Marcelo.
Thank you, Dr. Marcelo. Our next speaker is Dr. Sibel Scholz, and she's a researcher, and she's done a lot of work on IOL calculations and the IOL-Con online database. I'd like to welcome her for her talk.
Thank you very much for your welcoming words. I'm very, very happy and delighted to be again here with you together. I tried to share my screen. I hope it will work. So here we are. The usual question, can you see my screen?
Absolutely.
Wonderful. I try to use the presentation mode. as we talked about IOL-Con before on during your wonderful webinars, I will only give a brief overview over the general features of the IOL-Con web base, and I will talk more specifically on the new features IOL-Con offers right now. As I said before, and as you heard before, cataract surgery was changed by optical biometry fundamentally, and it's only 20 years ago. It's just around the corner from my time experience. Combined with the introduction of the first optical biometer, the Zeiss IOL Master, and Professor Heige's ULIP database of IOL constants, the way was very well paved for this successful new technology. ULIP was the very first database of its time, and it really set a milestone in providing IOL constant and most of all optimized IOL constants for cataract surgery. From our today's perspective, ULIP does not longer meet anymore the requirements of modern cataract surgery. To meet those modern standards and requirements, Professor Langenbucher developed Professor Heige's idea further, and he established a new internet web-based database for IOL constants. And in 2017, he launched IOL-Con, which is right now the utmost modern and most updated database for IOL constants. So just a quick overview. It's all about optimized constants of IOLs before cataract surgery for calculating the IOL power. Optimized IOL constants, it's impossible to do calculation of IOL power without them today. Ideally, you should use your individually optimized IOL constants for your specific surgeon style. Meanwhile, over the years since 2017, IOL-Con has established itself as a reliable, worldwide available source of optimized IOL constants and specifications. To me, it's an indispensable tool for cataract surgeons, for ophthalmic surgeons. Based on modern optimization strategies, IOL-Con also offers, and this is important to me, free of charge for ophthalmic surgeons, those individually optimized IOL constants. Let's have a quick overview or a look at the web base as it looked like. IOL-Con provides an up-to-date overview of available IOLs with all relevant technical, geometric, and material characteristics, as you can see here. The search options of the database are really easy to use in a variety of ways. As well, the data can be downloaded or printed as you like it in a very convenient way. Let's have a very quick look at the search options. You can search for everything you want, for the manufacturer, for the material of the IOL, the haptic design, the biometer which was used, the ethnic background of the patient, and many, many options more. Most important information at IOL-Con website is about the constants which were optimized by IOL-Con itself. Let's have a look at those, which can be found on the right side of the website. If you look at the browser, you see those optimized constants by IOL-Con on the right side of the website. IOL-Con uses a color coding system, like a traffic light system, to describe the quality of the optimization they did. So if there is a red square around the number, then the optimization is based on less than 100 clinical results. If it's yellow, then it's between 100 and 500. And if it's a green square around the number, then the result is based on 500 or more clinical results. This information can also be found on the website when you look at the footnotes. Here you'll find as well information regarding data of toric IOLs. The manufacturer who uploads his data of his respective IOL can choose either if he shows the refractive power as sphere or the refractive power as spherical equivalent. A very nice tool for me. If you use the mouse, the cursor of your mouse and go over the rectangle of the optimization, then a new window will pop up, and this window will show you the absolutely details of the optimization, which shows you all the detailed data behind what Professor Langenbucher did for optimizing this constant. This is a nice tool, and just play around at the website and try to figure out how to use it best. The method used by IOLCon for optimizing IOL constants is characterized as an intelligent IOL constant optimization, which uses, for example, statistical methods taking the measuring accuracy of the measuring instruments like the biometer also into account. Optimizations of the constants for the following published formulas can be found on IOLCon's website for Hygis, for HOFAQ, for Holiday, SRKT, and now, and this is one of the new features of the website, also for the very young Castrop formula. The first article talking about this very new formula is the one by Jascha Wendelstein, which you can see down here on my slide. He was the first talking about this new formula. And there are another 2 articles out there already published describing this formula, the idea behind the new formula. At least to my knowledge, the Castrop formula is the absolutely newest, youngest IOL power calculation formula. And according to the statistics of those articles, it shows superiority to SRKT, HOFAQ, Holiday 1, and Hygis. Please have a look at those 2 articles. You can download them. You will find them in the internet at ResearchGate everywhere. The nice thing as well, there's already a toric version of this formula available. And you can choose either if you want the simplification as a thin lens, or if you want to use the data of the real world thick lens cornea. And most important, this formula is also a published one. You find details in those articles about the formula, and more interestingly, you will find an online calculator soon in the next few days on the IOLCon website, which is using this, or which is showing you this formula, and you can use it on that website. What already now can be found on IOLCon's website is if you do a printout, or if you look at the printout of one of the IOLs, you can already see the optimization for this new formula. As you can see in this red, I marked it, highlighted in red. You see the optimization for the Castrop formula already is available on IOLCon's website. So if you want to benefit from all the features IOLCon offers maximally, then please register at IOLCon's website, which is really easy. Just go to the main website, click on the contact button, and then the next window opens and shows you this slide. Please enter your name, your email address, click the button, register as new user, and then simply send the form. After that, the colleagues from IOLCon will get in close contact with you, share the login details with you, and then you can upload your post-refractive results to get your optimized, personalized, optimized constants. You have 2 options to upload your post-refractive results. Either you want to use an Excel sheet, you can download it here from the website, or if you prefer to use an XML spreadsheet, it's also possible according to your preferences. So almost in conclusion, the benefits for you as a surgeon are quite clear. After uploading your refractive results, you will receive your own personally optimized constants, only for you, free of charge for you. Optimized global constants are based on community data and can be used without registration, just checking the website. To me, IOLCon offers much, much more than only a simple Excel static table. It's a global, interactive, most up-to-date, most modern internet platform that provides ophthalmic surgeons with the documentation of all IOLs and all the characteristics of the IOLs, and which are updated constantly. To me, by implementing IOLCON, a biometric database is now in place, which will also meet the ongoing demands of an ongoing developing ophthalmic surgery. If you are interested in something, if you want to know more about IOLCON, then please check out for this publication. It was recently published in a German ophthalmic journal, Klinische Monatsblätter für Augenheilkunde. It's in English, and it shows you all the details about IOLCON, about the theory and the basic behind that database. Thank you very much for listening to me.
Thank you so much. I think,
thank you so much.
Yeah, I think that's the need of the hour for all cataract surgeons, and getting our results right and hitting the needs of the ophthalmic market. Talking about the ophthalmic market, our next speaker is Mr. Peter Downs from the US, who has more than 30 years of experience as a business and medical journalist and investigative reporter. He's with MarketScope, who he joined in 2015. And he'll be talking to us about the glaucoma and retina market beyond cataract market. So over to you.
Thank you. Have we moved over?
You have to share screen. Perfect.
Thank you very much. It's been a fascinating morning of talks, and now, as we're taking a hard turn into the market environment where new products, such as discussed today, have to find a place. And since cataract is the dominant surgery in India, I'm looking beyond cataract at glaucoma and retina. So this first slide is looking at the global market. Worldwide, we spend about $6 billion in treating glaucoma, $16.2 billion on treating retina. And you can see the surgical slice of that, and which I think is the theme today, is quite small, only about 1/7 of the glaucoma market, maybe a 10th of the retina market. In India, it's a little different. Spending is about 181 million for glaucoma, and you see that the surgical fraction is about 3/4 the size of the medical fraction. And in retina, it's about a quarter of the size. And that reflects both that the lateness of diagnosis in India. So in glaucoma, for example, so many cases are diagnosed late that medicines would not be effective. And so they go directly to surgery. And also the low price. Medicine prices are very low in India. And also they're offered in very small containers. I've seen containers of just a couple days worth of hypotensives offered on the market in India. We have a problem worldwide with lack of adherence. It reduces the effectiveness of medication, and it's probably more pronounced in India. So we look at, and people looking in the market look at several things in estimating how the market will grow. That includes the growing number of people living past the age of 60, the growing population of people with ophthalmic diseases. The example here is retina, access to treatment, the development of new therapies, competition within the market for therapies, regulation, which may slow or increase use of therapies, and of course, the safety of various interventions. So in India, we estimate that there are over 22 million people with glaucoma. Fewer than 3 million are being treated by medication. About 186,000 get about 186,000 laser treatments will be offered this year, and surgery will be performed on about 48,000 people. For retina, we're approaching 15 million people with vision-threatening retina disease, of whom only about 1/10 are getting medication treatments. And again, laser being used about 122, 123,000 times this year, and about an equal number of surgeries. The trends we see in the market are increased competition. Competition is very intense already in India, but you see increased products on the market for both glaucoma and retina worldwide. In glaucoma, an increased use of generic medicines, and we're looking at the introduction of biosimilars worldwide in retina. I know there are biosimilars already on the market in India. Cost controls are a big deal that can in regions across the world. In glaucoma, certainly surgical and laser markets are growing faster than the pharmaceutical market. And we're going to see a little bit different in India. And there's targeting new diseases, such as the potential to treat geographic atrophy in retina. In India, things are a little different. Competition is very elevated. And in part because of that, it's a low priority region for manufacturers to introduce new products. For example, in glaucoma, with 2 new drugs reached the market in the United States in 2019. They're still not marketed in India. One of them has not reached commercialization yet anywhere outside the United States, though they've been trying in Europe and Japan. And the other one has picked certain limited markets to expand to from the United States, like Canada, Argentina, Taiwan, and Qatar. India has not been in their top tier. We see increasing access to diagnosis and treatment. I know there have been programs launched in India to increase training for diagnosis of glaucoma diseases, for example. But there's still strong pressures on affordability, which limit treatment. And there are local versions of products. So our forecast for the India glaucoma market, looking ahead 5 years, you'll see about 60% of the market will be medication, a little bit less than now. And on the left, it looks at the different classes of medications, alpha agonists, prostaglandins, et cetera. Diagnostics are about 40 million. And in surgeries, MIGS is probably the fastest growing. Trabeculectomy is the dominant surgery in India, but you don't use a lot of products in it. So manufacturers don't make a lot of money on it. So that part of the market is little. For retina, again, we see medication accounting for 3/4 of the market, and surgery about 15%. Branded ocular anti-VEGFs are preferred by people who can afford them, and they would account for almost half the market. Off-label cancer drugs are like Avastin and Zivaflibercept. Of course, biosimilars, other pharma. Vitrectomy, we see it reaching about 46 million. Other surgical devices are often devices used as adjuncts associated with trabeculectomy. I'm sorry, run retina now. But other surgical devices, then oil, gas, and dye, and laser and probes. So we look at factors that both kind of depress the market and factors that increase it. Factors depressing market revenues include, of course, competition from generics and biosimilars, better patient stratification, so you can better select which therapies to use at different stages of the disease, rather than having to go for kind of the canon right off. Cost controls, insurance formularies, as insurance spreads in India, step therapy. New products are often, not always, but often competitively priced. So in retina, for example, new products are usually priced at about the same level in medications as existing products, but offer longer term of action. So that tends to reduce the number of treatments over a year and the total market revenue. And then there's surgery versus medication. And as said, in glaucoma, there's a trend towards surgery to replace medication. In retina, in the US at least, with the introduction of surgery now for an extended release medication, and that probably won't reach India in the next 5 years, but will affect the global revenues. Factors increasing market revenue are, of course, the increase in the 60-plus population, growing disease rates, rising incomes as people can afford what they believe are more effective therapies, and, of course, more effective treatments. The Hydrus from Ivantis, or recently bought by Alcon in glaucoma, has shown the ability to reduce the progression of glaucoma in over 40% of cases and reduce the need for later glaucoma surgery by about 2/3. And of course, new products that can extend accessibility of treatment to more people by reducing the burdens of treatment and costs will increase the total market, and treatments for previously untreated diseases such as geographic atrophy. So all those figure into our forecast that you saw earlier for 2026. Key forecast components then are, of course, the people with glaucoma or retinal disease, diagnosis rates, treatment rates, frequency of treatment, adherence to treatment, the type of therapy, and sales prices. So one thing we can't predict, of course, are what new technologies introduced will actually disrupt the market, but some that have the potential clearly to disrupt. In glaucoma, low-cost automated SLT, repeatable, cost-effective, sustained release devices. There are 21 companies working on that. Neuroprotective or other agents that prevent and reverse glaucoma progression, and there are at least 5 companies in clinical trials with those. And effective non-specific gene therapies. In retina, there'd be a treatment for GA that actually reverses disease damage. Effective topical drug delivery could change the whole accessibility and adherence to treatment. And there are 13 companies working on that. Effective oral drug delivery, with 18 companies working on that. If someone is successful doing that, that could change the whole burden equation around treatment for retinal disease. And effective non-specific gene therapy. So thank you very much for paying attention. And back to you, Dr. Sethi.
Thank you very much, Peter, for a very nice presentation. And I think it was extremely nice of you to come in and tell us what's happening. And we look forward to working together and seeing how we can develop the Indian market. It's the largest market after China and the most cost-sensitive market, as you've been here 3 times. So we look forward to many more interactions with you and your company and hope that you'll come and work in India and open an office here. So we now request the next speaker, and I request Dr. Aditya to introduce.
Our next speaker is Dr. Arpan Gandhi, Associate Medical Director, Chairperson, Shroff Charity Eye Hospital, Delhi, and Secondary Center Labs. So over to you. So I was going to talk about ocular microbiology.
Can you see my screen?
Yes, sir.
Okay. So thank you, Dr. Aditya, Dr. Reena, and Dr. Arun, and of course, Dr. Vaibhav. So just changing the flavor and also continuing the flavor of the webinar, we realized that we see a lot of corneal infective keratitis, corneal scars, bullous keratopathies, and keratomalacia, and lots of diseases which actually require a laboratory support. Ocular microbiology, when we started about 5 years ago, was very limited to secondary centers and hospitals. We got into a program where we started training different centers and different ophthalmologists to start setting up small ocular labs. And we continued to do this, and we realized that over a period of time, the outcomes and the targeted therapy was much better after we could actually get them to start doing this program. We continued this and provided them with facilities and trained them on doing gram staining and KOH and picking up basic microbiological organisms so that their therapy was immediate and appropriate. We trained ophthalmologists, assistant paramedic staff. We had a unique program where we had 40 to 50 young women. And this was a program which was unique in India, which was run completely by allied ophthalmic personnel who were women. And they were part of our program, and we spread them out to train different centers. And I'm just running through the slides. I don't want to get into the details, but basically we tried to cover everything that a basic microbiology setup would have. And we're proud to say that we were able through our program to train 40 to 50 of ophthalmic setups, and they are now, all of them have basic lab facilities. And in fact, we've now taking this to level 2, where we're going to get them to establish a bigger and a more specialized lab. And we already have 10 people who are getting trained in this. So we want to reach to various centers all across India, so that there is no patient, whether it's a farmer or a corporate person, to go with a corneal ulcer or a lesion without getting a basic diagnosis done. So we wanted to share this experience with all of you to tell you how varied our learning across the last 5-6 years was. And we're happy to have actually been part of this learning process, and also to learn, also to teach people. Basic facilities like transport media and how to get things across to various labs was part of our program. These are a few pictures of actually what was done during the training and people who were part of the training. There was strong telecommunication. We had a electronic medical record established. And then, of course, COVID taught us to be better digitally, and we had an ocular digital microbiology setup too. So it was reaching the community and providing quality care. And we hope through this, the huge burden of diseases, especially corneal diseases, we're able to form a good quality microbiology service and also bridge the gap between the urban and the rural healthcare facilities. Just like all of you have shown some fascinating videos, this is something that we captured under our microscope, and this is our fascinating, or our, I would like to call it the wonder. So just 2 seconds. So this was actually a mucosal biopsy, which I thought there was an eye staring at me. This was a man trying to break free. It's actually a mucosal gland biopsy for people who, and this is something I created when I addressed the global webinar, and we thought there was pathology all over, not only, and I hope ocular pathology and microbiology would be all over. And this is actually incubated secretions, which was giving you a thumbs up. So thumbs up for this. And thank you so much for letting me be part of this global webinar. Thank you.
Thank you very much, Dr. Atman Gandhi. It's been an excellent presentation, precise, and lets you know that how in the developing country we can achieve a lot of benefits clinically with low investments. And I hope you continue your good work and visit us at Arunodaya. We can duplicate this in our hospital also. We now move on to our last speaker of the session. That's Dr. Sahiban Sethi. Now I've been asked to introduce her. Dr. Sahiban Sethi, the main the introduction is that she happens to be the youngest daughter-in-law of our family. And she joined our family when she married her younger son, Dr. Aditya. It was a love marriage, and they met in Shankar Netralaya. Apart from that, her academic credentials are excellent. She did her MBBS at the Ramchandra Medical College in Chennai, and then did a fellowship at the famous Shankar Netralaya, where they run an eye-to-eye program, which later on turned into a love affair. Dr. Sahiban Sethi runs the glaucoma service at the Arunodaya Deseret Eye Hospital, and I now ask her to make her presentation. And after the session, there will be a screenshot of all the faculty members of the session smiling right up at the molars. So please stay on with us.
Thank you so much for that very detailed and personal introduction. It was very sweet. So what I'm sharing is tips and tricks on trabeculotomy and trabeculectomy. It's a short 5-minute video. So I'll start now. Trabeculectomy, tips and tricks. Combined trabeculotomy with trabeculectomy is the surgical technique of choice in primary.
We can't see your video.
You can't? Okay. Just a minute.
congenital glaucomas in Indian pediatric population, owing to more severe disease compared to Western pediatric population. It can also be undertaken in cases where previous angle surgeries have failed and in hazy corneas. It has shown to have maximum success rate when performed less than 3 years of age. The rationale behind doing this combined procedure is to obtain access to dual outflow, namely through the Schlemm's canal and the trabeculectomy fistula. Particular challenges of this surgery include small palpebral fissure, less rigid and thinner sclera, and different than expected location of landmarks in ophthalmic eyes. Surgical technique. Corneal traction suture is taken using 6-0 vicryl suture. Conjunctival dissection can either be limbal-based or fornix-based, like in this video. Limited wet bipolar cautery can be done at this point if required. Care must be taken not to over-cauterize the episcleral tissue owing to thin sclera due to ophthalmos. Merocel sponges soaked in 0.2 mg per ml of mitomycin C is applied for 2 minutes, sparing contact of the edges of the conjunctiva with mitomycin C, and then washed well with copious saline irrigation. A 4 by 4 millimeters triangular partial thickness scleral flap is then made using a 15 number blade or a crescent knife. A rectangular flap can also be fashioned. Ensure at least 50% thickness of the scleral flap for adequate coverage of the sclerostomy hole after the trabeculectomy. Also, with a very thin or a thick flap, limbal landmarks may be missed. Finding the Schlemm's canal is an important step in trabeculotomy surgery. First clue. Presence of a small scleral vein entering the Schlemm's canal is an important sign for its location, as these veins drain the Schlemm's canal. Second clue is the junction of the white and the blue zones. It's said, where white meets blue, Schlemm waits for you. Third clue. Look for a slight depression at the junction of the blue and white zones, which corresponds to the location of the Schlemm's canal. Once the landmarks are identified, a radial incision is carried out very gently and slowly with careful deeper cuts until a gentle ooze of aqueous is noted. In case of doubt, a 6-0 nylon suture can be used to facilitate the identification of Schlemm's canal by an easy cannulation of the suture without resistance. The location of the incision is very important, as a slight posterior incision may lead us in the supraciliary space. After locating the Schlemm's canal, a Harm's trabeculotome is inserted into the Schlemm's canal and should pass through without any resistance. It is then rotated inside and upward towards the cornea. Care is taken to avoid damage to the cornea. Same procedure is repeated on the other side. One must not rotate the trabeculotome in the plane of the iris, as the base of the iris may be at the level of the Schlemm's canal. A slight hyphema is normal during this maneuver. This way, trabeculotomy is completed over 4 to 5 clock hours. Now we turn our attention to completing the trabeculectomy. The anterior chamber is entered with a 15-degree side port blade through a separate opening more anteriorly. Sclerostomy is done using a Kelly sponge followed by an iridectomy. The scleral flap is then closed using 10-0 nylon sutures and knots are buried. Releasable sutures can be used as well, which will be the surgeon's call depending upon the case and his clinical decision. The overlying conjunctiva is then closed using 9-0 vicryl suture, ensuring a watertight limbal closure. At the end of the surgery, make sure you check for any bleb leaks using fluorescein dye under red-free light. Subconjunctival injection of antibiotic and steroids is given at last. Postoperative follow-up is extremely critical. After the initial postoperative period, patient is followed 6 weekly and Examination under anesthesia may be needed till the child is old enough for slit lamp examination. During the follow-up examination should include applanation tonometry, axial length, corneal diameter, gonioscopy, fundoscopy, retinoscopy, and slit lamp examination for corneal clarity. Thank you.
Thank you, everyone, for your kind attention.
Dr. Arun, you're on mute.
Thank you very much, Dr. Saiba, for a lovely presentation. We now conclude the 2 sessions that we've had, Pan Ophthalmologica 2, and for the tremendous response that we've received from ophthalmologists across the globe, running into a few thousand. We take pride that we have such an eminent faculty dedicated to the cause of prevention of blindness, and we look forward to working together in any format that we can. We now request for a screenshot and wish you all a very happy Sunday and enjoy the day with your family and friends and safe and kind health. Screenshots for everybody, please, Dr. Aditya and Dr. Weber to coordinate. I'd also like to thank Mr. Rahul Jain and Mr. Kushagar. Could you please come on the screen now? These 2 boys have worked hard behind the room to make this webinar a flawless one. We have now reached this international standard of webinar. So in times like this, if you ever want to hold a scientific meeting, do use us as your consultants. Thank you very much. We have taken the shots now, and thank you very much. And if anybody would like to say any concluding remark, you have 30 seconds each. Thumbs up for a screenshot together. Everybody please thumbs up. Dr. Hudson, yes. And thank you. And as you can see, the Dr. Hudson has the lovely maroon colored wall behind him. And, yes.
Thank you.
See you soon all together. Dr. Weber, thank you for conducting a very well organized and a disciplined webinar. We were just 20 minutes over time, and that's a great thing to happen in a webinar of this nature. Bye-bye and good night to you all. Stay safe.
Thank you very much.
Aaron. Hey,
Bye-bye.
Great organization. Aaron,
Bye-bye.
you're awesome.
It was
Thank
great
you.
as always. It was wonderful to meet you all.
Lovely
Thank
to
you
meet you
all.
too. Bye.
Thank you all.
Thank you.
Bye.
Bye-bye.
Bye.
Super seminar. Thanks.
Thank you.
Thank
Lisa.
you. Bye, Lisa.
Bye.
Bye, Aditya.
Bye, Dr. Hudson.
Bye-bye.
Bye, Vaibhav. Thank you.
Okay, Rahul. Bye-bye. Bye.
Recording stopped.
ठीक है, okay.